So just to everybody, the committee will be recorded and broadcast throughout Parliament buildings and online. Alan Chambers is to be joining us online. Hasn't come on yet. Is anybody aware of any apologies?
Yeah, indulge.
Okay. I have no business this week. Draft minutes. Can I refer members to the draft minutes of the meeting held on 25th of September? And are members content to agree the minutes? Okay.
Content.
Matters arising? None? Okay. So moving then to item number 5, oral briefing from the RQIA. Can I refer members to papers in our pack, including page 14 of the main pack, and also there's a letter from SWAH on page 3 of the table papers. So, can I welcome Briege Donaghy, Chief Executive of the RQIA, and Christine Collins, Chairperson of RQIA, Regulation and Quality Improvement Authority. I've never actually read out the full title before, so it's good to do that once every now and again. So, can I welcome you both to the committee? I'm going to ask you to give us a brief opening statement if you so wish, and I know you have provided us with a written briefing, and then we will go straight to questions from committee members. I know you are time constrained as well.
Yes, thank you very much, Chair, and thank you very much to the committee for the opportunity to update us on, or update you on what we're doing. I'm sure the world knows us best for our role with the registered health and social care services, so that's care homes, nursing homes, dentists, those registered services. But I would like to use this opportunity to set out our role in relation to the trusts, the statutory sector, because I think that's perhaps less well understood. So I'd like to briefly cover our role in trust services, our role as a mental health commission, the commissioning of reviews by the Department of Health, and how we go about providing improvement support to the HSC sector, and then some of the other issues that are currently raised with us. I think it's important to be aware that, in contrast to registered services, trusts actually have a statutory duty of quality on them that was introduced by the 2003 order. So they actually have two huge duties on them. One is the duty to break even, the financial duty. The other is the duty to provide quality in services. And linked to that, we have statutory functions to review, investigate and inspect HSC trusts for their performance of the duty of quality and against quality standards which are set by the Department of Health. And that's entirely different from the position in the registered sector. We in RQIA produce reports, we can serve an improvement notice, but we cannot put conditions on trust services. So if we see something that's not quite right, we can report on that, we can issue an improvement notice, but we can't actually do anything beyond that. It's for the department and SPPG. Trust acute hospitals, community services, are not currently subject to regular RQIA reviews, investigations or inspections. Again, that's unlike registered services where we have to go and inspect them once a year or twice a year, or so for once every 2 years, I think now, if you're a dentist. We do inspect inpatient mental health hospitals and units in the HSC trusts because that's part of our role as the Mental Health Commission since 2009. However, there is a need for us to expand our functions into the community services, including especially the supported living facilities, and there are wider issues about access to mental health facilities for people living in their own home or with family, because the service model's changed so much. It used to be anyone with mental health or learning disability went into an institution. Now they're more likely to be looked after in a community setting. That's thankfully that change. I mean, much better for people not to be institutionalised, but we still need to have an eye to where they are. Moving on to the Department of Health and their commissioning, they can commission us to undertake reviews and investigations, and they did so. So we undertook a review of the records of the deceased patients of Michael Watt, first One first tranche of that was published in November 22, and we're working on doing 2 more sets of families at the moment. The importance of culture and behaviour in ensuring patient safety just emerged screaming from those reviews, as indeed I think it's emerging from looking at all the inquiries that are going on. That culture and behaviour is key to having a safe environment for patients. And as a result of that, and as a legacy of it in a sense, we've facilitated the co-production with the health and social care system of a shared safety culture framework. It's called Being Human, because I think the group that worked through that across all the sectors, including patient representatives, family representatives, realised that actually humans are key to this and human behaviour is key to it. So it recognises that the culture of all HSC organisations needs to change, and people need to feel safe, they need to feel respected, they need to feel able to speak up, to get answers, and to see changes made. And I think that, to me, that's an example of RQIA enabling and supporting improvement across the HSC sector at a very deep level. And we're delighted as well that last year the department transferred the HSC QI function from the Public Health Agency into RQIA. And from this week, we've welcomed the addition as well of Project Echo, so that greatly strengthens our capacity in this vital improvement area. And that sustained improvement and cultural change is just so clearly needed. I mean, it comes wherever you look. There is, must recognise, tremendous good work is carried out daily by the many dedicated staff across the whole system. But by the nature of our role, we most often hear of issues when things go wrong, or people are concerned because they feel or they know that things aren't quite right. And we've included some information in our briefing about our role where people have contacted us under whistleblowing. And people do contact us under whistleblowing. Over 100 did so last year. But the thing is that whistleblowing protects people's identity, gives anonymity. So we can't go shouting from the rooftops about that, but it is something that we pursue very rigorously. And we're also contacted by patients and their families and their advocates. And some of the issues raised by them in recent months include cardiac surgery, and obviously the services in the emergency general surgical services in the Western Trust. In our view, the use of management consultancy to provide insights and highlight issues of concern, which was the case in the cardiac surgery in the Belfast Trust, whilst that's very valuable, it's not a replacement for statutory regulation. Where service change happens either by intent or in a crisis, you have to have continuity, you have to have a gathering together of all the relevant information, and it's essential then that clear information on outcomes is made available to the communities that are affected by those changes, and that their experience is heard and valued, and that actions are taken as a result. And this goes back into the culture point that we've got to get the culture right so that that happens. So I think the authority is very firmly of the view that a strengthened statutory regulation role is required to provide support, to encourage improvement, and to provide evidence to trust boards, to the department, to the public, I mean, indeed to yourselves, about the quality and safety of services. And the authority very much hope that the quinquennial review that the department is about to undertake, which will look at the role and functions of RQIA, will address these matters. And we're keen that stakeholders, and especially the public, are fully involved during that review, because we're really looking to say what type of regulation is needed for health and social care in Northern Ireland now, but also into the future, what needs to change in the legislation, and how will regulation be funded? Those are 3 key questions. And we trust that the review will engage with stakeholders on these very important issues. And thank you, Chair, for giving me the time to make that. Okay,
thank you. That's been very useful. So, in the information you've sent us and your opening comments, you said that you make reports and improvement notices Just explain what an improvement notice is and what the difference it is, because you're saying here you can't set conditions. So what's the difference between setting conditions and issuing an improvement notice?
Yes, I'll take that as best I can. An improvement notice in the health and social care for a trust is this outcome, usually from an inspection of some kind. Although we don't carry out inspections routinely and regularly, we do carry out some inspections. And as a result of that, we'll produce a report. We'll make recommendations in the report for improvements. But if we're concerned about those improvements, about the pace of need for change and the urgency of them, for example, we can produce what's called officially, if you like, an improvement notice under the legislation. That improvement notice is published, made available to the trust, obviously, within, I think, 3 days of the decision being made, and is published on our website and sent out to all stakeholders, of which there be many around the province. So whilst it might be seen as, quite a modest step, because it sets out what needs to change and the time frame for its change and how it'll be evidenced, it doesn't actually have any other, what's the word I'm looking for, conditions set. There are no conditions set on it. And so the trust, in those situations, it would be relatively rare to serve improvement notices, but where they are served, the trust do take these extremely seriously. It will mean inside the trust and the trust board and senior team making resources available, making sure that they've got an action plan, taking actions and evidencing progress, engaging with RQIA over that period of time to keep us informed, etc. The fact that it goes in the public domain also means it becomes available to media, to families, to others. So there is an organisational, reputational aspect to it. But that is the only, that I can think of, formal action that we take in the current legislation around trusts. Conditions would be part of the regulations of services that are registered. So those are services that pay us a modest fee. To register, a care home has to pay a fee, £942 of that to register, a certain amount each year. So do trusts have to pay that as well if they happen to run a care home or a children's home, for example. Those fees were set 20, 25 years ago and haven't been changed. But where a breach of regulations occurs for a registered service, then you can also put a failure to comply notice on that. You can put an improvement notice and you can set conditions. So, for example, you could say in a care home, I don't mean to always be choosing care homes because it could happen in a children's home or a private hospital. No more admissions, for example, until this aspect is remedied. And the organisation must comply with that. It adjusts their licence. It adjusts their statement of purpose, if you like. So they must evidence and remedy the issue before they can recommence. In some cases, it might be a case of a new organisation that hasn't actually taken on any residents or clients, and the condition might be you're not to start accepting new residents or clients until you inform us and we're satisfied you're ready to commence. So those sorts of situations are not part of our remit in the NHS Trust, HSC Trust, and I would quickly say we're not suggesting they should be. Northern Ireland's a small system. We keep hearing this idea of the trusts and others, all of us, including independent providers, working together as a whole system. So setting conditions like no new admissions to a ward or a service would have very significant implications for the wider system. I don't know when those who were writing the legislation thought of it like that, but it's something we certainly reflect on now. So, this whole idea of legislation, being outdated, there's no doubt about that. But we're not arguing for greater powers in that regard. The legislation actually in the HSC side, as Christine has described, as it was described to me on one occasion, provides us with a very broad umbrella. We have the authority to inspect. We don't have regular inspection programmes of the HSC trusts or reviews even for that matter. But we do have the authority to inspect or review or investigate. You hear from us quite often, we don't often have the capacity to do it at the scale we think would be helpful.
Well, you're kind of leading me on to my second question, because in the middle of your answer there you said that fees haven't been improved in 25 years. So And you've talked about resource as well. So if you had additional resource, what additional work could you do, particularly with regard to the trusts, and I mean even further to that in relation to governance, because you mentioned the cardiac unit and other things like that. So if you had more resources, what additional work could you do?
I'll have a go at that. I think what the authority would very much like to see is a bit of a rebalancing, because up till now we've been really very much focused on the independent sector and on the registered services. And I think we need to rebalance, and we need to start looking in more depth at the HSC side. So if we had the additional resource, and it was down to me, I would be putting that resource into the improvement arm of the RQIA, but also this investigation review activity, and start looking at the mechanisms that trusts are using, their information flows, their ability to analyse their information, their data, to make their services better. Because I think we haven't looked at that, and it hasn't been, I think, systematically looked at for a very long time. I think the last time there was a governance review of the trust was in about 2007,
8, 9, something like that.
So I think that's an area that definitely does, but we would need to get the capacity to do that and build up to that, to put that into effect. And that's why I'm sort of hopeful after the work we did on the Being Human framework, because I think there is an appetite now throughout the HSC to actually work at this, and to, everybody to come together and work to make the system better. I was really, for the first time, I think I began to feel a little bit optimistic after the work on the Being Human framework, because that just seemed to strike a chord, and you could feel in the room people going, yes, we want to do this, and we can do it. We have the mechanism through this framework to actually achieve that. So that's what I'd like to do. I'm not in any way advocating that we go in sort of with squads of people looking into cupboards and so on. I think we need to work in a totally different way to bring about the improvement. But also there has to be rigour to it, and that's Briege. I mean, in the trust sector, our nuclear bomb, if you like, is that we can recommend special measures to the department. If we find a situation where a trust has persistently failed to improve, we can, in fact we must, it's our duty to report that to the department and to recommend that the department take the special measures. But it is for the department to do that, it's not for us. So there is that clear divide.
Okay, thank you. And then just finally, before I bring in other members, so you've outlined and you've mentioned it there about the need for clear and accurate information being made available to communities when services are changed either by design or not by design in emergency circumstances. You'll be aware the committee were copied into a letter from SWAH that was sent to yourselves. So Christine, you were saying that the community's experience must be heard, and I mean it seems to be the case in the letter. No, SWAHs are saying that when you were doing your work, that there's an overwhelming amount of evidence provided directly by patients and staff, whereas you have looked specifically at clinical outcomes. So I'm just not sure how you would want to respond to that.
And that one to Briege, but I think just to sort of reassure you, we do look across the entire screen. It's not as if we just solely look at the clinical data and the statistics. We do listen very carefully. But Briege?
Yeah. Well, on the basis of the letter that SWAH's colleagues sent to us yesterday and that you've evidenced, I think they were referencing a recent meeting with myself earlier in September. And that reflection on looking currently at clinical outcomes is a snapshot, if you like, of a piece of work that's going on or that is important now. It's not to say that's exclusively what RQIA look at in terms of evidence, safety and quality. It simply isn't. But it is recognising that clinical outcome information in meaningful format, we believe should be available to communities, to populations, to groups of individuals, where there is a service change, whether it's in the West or elsewhere, whether it's by intent or by crises, but where there's change, there should be evidence to allow people who've been directly affected to be able to be assured of the clinical outcome under that new model, regime, pathway, whatever you want to call it. Is that the only thing that's important? No. It's a fundamental aspect of it. But also a whole range of other factors come in, and putting it simply, access to the service, experience of the service, both for those who work in it and those who are recipients of it. Those are all factors when you look at safety. It takes us into that whole world of the being human and the culture. You know, I suppose I would be saying is we need to normalise the idea of respectful challenge. We need to normalise the idea of openness. We need to normalise these processes. So yes, we're very interested in clinical outcomes in that particular area, but not exclusively. We have spent time in recent weeks since the review. The review was made available to the Trust and to the Department a year ago. Since that, have families contacted us? Yes. Have advocates contacted us? Yes. Have we been listening to them, speaking with them, engaging with them? Yes. In fact, I would say that's an area that the focus has been on, is engaging with families and with others, SOAS and others, about experience of the service. But it's also necessary for us to look at what are the outcomes from the service. Now, the Trust very reasonably put in the summertime there, put some information in the public domain about outcomes. But people have raised with us, difficult to understand, not that easy to demonstrate that it actually relates to this group of, this community, and we agree with that. We think that information should be open, should be shared, should be meaningful, shouldn't be complex. There's no reason for it to be. It can be explained simply. But I would absolutely, point out that, as Christine says, that is not exclusive what we're looking at. I happen to be chatting to the colleagues who raised it, and I absolutely accept the point. I have a focus on that at the moment. That is an area I'm absolutely interested in, but not exclusively. And we always look, when we were here last time speaking with you, we explained that we look through, if you like, triangulate sources of information. The patient experience, and what they've described, and staff, coupled with quantifiable information, clinical outcomes, incidents, registers, risks, all of those things, and ultimately observation. So we go out and observe. Those are part and parcel of the tools. So we're listening, we're looking at data, and we're observing. Those are the things, and we will continue to use those. So, no, I'm not exclusively looking at clinical data, but I do think it's important.
And then, Briege, you've talked about being human there a couple of times. Is that a new name for the open framework?
No, but it's a great opportunity to explain. The being open, and we know that's still in development, it would be, as far as I can understand, is the department, with all of our support, I'd have to say, everybody saying, look, there's an absolute necessity for being open, being transparent, sharing information to be normalised, to be the normal routine, not just when things go wrong, but in ordinary times. And my understanding and my modest involvement in it, that will develop a framework and policy procedures as to around, well, how do you do that? What's the, how would that happen? What would be the mechanics of it? What would be the evidence for it? But the being human is much more about what we say, what we do every day, and how we say it, how we do it, the tone that we're setting. It's this idea fundamentally underpinning everything. It's about choosing our behaviours as individuals, as organisations. It's not a policy document. It's not a tick box. I have to be able to show I've done that and that and that. That is not what it's about. It's about changing the culture, which we know when you walk into a place, as we have done today, you sense the culture, you know what the culture is. That's the same in the health system. We have to change that because it's been demonstrated time and time again that staff don't feel safe to speak up on many occasions. Some bravely do. Others in some organisations are supported. 100 people were brave enough to speak to us last year about their concerns. So it's not that it doesn't happen, but it must be the normal. And it's really about asking people to take ownership of their behaviours. It would underpin all of those other things. So when Being Open comes in and explains and asks us to be consistent about how we are open, then it would be sitting on a framework of organisations committed to being open, to being focused on learning, to want to listen to patients and families, to value it. It's the more the how as opposed to the what. But it's hard to do because it's quite hard to, easier to write documents that require you to present some tangible evidence, produce a document, name a speak up champion. They're all useful things to do. This is harder because it's that softer area of work. It's the sensing of it. So it's hard work. But the great thing about what's happening here at the moment in Northern Ireland, despite all our challenges, the HSC trusts, chairs, chief executives, the Department of Health, the Patient Client Council and the many others I've forgotten have all agreed to do this together. However difficult, we know it's not going to be solved in a week or two or even a month or two. But it's a real commitment to change so that staff and the public and patients, that there is an honest respect, listening, learning, all of that. But hard to do. It's more difficult to explain these things when they're not policy documents. But it is a collective willingness to change our behaviours.
Okay. Much needed in some aspects, so I appreciate that. Nuala?
Thank you very much, Briege and Christine. And just to say, from the start, I know that you get a large volume of correspondence. I am copied into a lot of that as well, and I'm sure others are the same. And I have appreciated being able to pick up the phone and reach out for queries. I think that is helpful for us as elected reps. And it's not the case for all across our health portfolio, so we do actually appreciate that and being able to reach out. I have a few questions around whistleblowing and then your powers and responsibilities, and to just start on following on from one of Philip's questions around the SWAH campaign. In terms of your inspection, on the referral pathways and the recommendations, where are we, or we're currently sitting with those, and in terms of have they been accepted? And like it has come up a committee. We're have a written briefing as our next item. But I wondered if you could.
Happy to.
No, I would just like to say yes. Just to reassure everybody, we've not taken our eye off that ball. Mm-hmm. We did do that report commissioned by the department, or review commissioned by the department within its terms of reference, and we're still keeping a close eye on what's going on. I think you're getting an update report later on today. We haven't seen that, so we don't know what's in it. We'll be agog to find out. But we are asking questions and we're seeking to get updated. But Briege is over the details.
I'll say briefly, and then you mentioned there, Neil, we did an inspection, although I would just qualify, we did a review because I know, but I get it wrong loads of times as well. But they are different. Because out of inspection, as I mentioned earlier, you produce a report, you make recommendations for improvements, you could serve an improvement notice. That doesn't apply with a review. Mm-hmm. A review is standing back, looking at good practice and looking at those things I mentioned earlier, observing, you're still out observing, using the same methodologies if you like, you're speaking to people and you're examining data and what have you. But when the review report is produced, the current mechanics for that are that it was commissioned by the department, so they're the commissioner, they're the people we send that report to. We also send it to the trust, we make our recommendations, and at that point, ordinarily, that is left between the trust board and the Department of Health through the SPPG. That is the accountability mechanism for that. Ordinarily, RQIA are, in my time here, rarely involved thereafter, bar where Maybe the department may ask us to look at something in particular, to follow up, to strengthen something. The trust may ask us to clarify something or help with something. Or if we get sufficient evidence of things that are going wrong or problems in that service, we could very well undertake perhaps an inspection. That would be a different premise. On this occasion, largely the reason why we, as Christine says, are very much interested in the outcome of that is in the public domain and the progress reported against it. Look, we welcome that. You know, in fact, I've said to SWAH colleagues when I met them a few weeks ago, you know, well done, Trust, for putting information in the public domain about progress you are making against RQI recommendations. That's rare. Quite often these things are done, you and I don't see them. So, you know, we would encourage people to report it. And that's really good. Now, the problem is in here, on one hand, be complimentary, and the other hand, take it away, because the information that's there is quite difficult to read. Doesn't actually give enough evidence, I would say, to be absolutely assured about the actions that have been taken. That doesn't mean they aren't. And it may well be that there's further evidence, and maybe in the effort to keep it simple and make it, you know, easily digestible, maybe there's something missing there. I don't know. But certainly some organisations and individuals and ourselves, you know, would like, now that it's in the public domain, I think it is important that there's clarity. So we're following up on that. I've explained that to colleagues who've asked us about it, and following up with the SPPG and with the department, and indeed with the trust as need be. Let's get some clarity on that. Look, it's not about us washing our hands off it. You know, none of us can do that. But it's encouraging the trust are willing to put the information in the public domain. But now we need to help and support them and others to make sure it's actually meaningful to those that it affects.
Well, thank you. I think that is helpful. And moving on to my next issues around whistleblowing and your powers. You said 101 occasions staff contacted, and half of those on care homes. Is that alarming? Should we be concerned about that? What kind of whistleblowing are you talking about with regards to care homes? Because in my mind, I'm thinking some of the most vulnerable, the people that need us to look after them. And do they? Yes. What happens after that? Do they always necessarily need an inspection or?
Well, yes, I think it was 103 we had last year, a similar number the year before. I'm not alarmed about it. You know, in fact, the more we can promote the knowledge that we are there to be contacted when staff, current, former, in the independent sector or the statutory sector, they can contact us. They can also contact NISC. We are the bodies that have carried out that role independently. The types of things people raise with us, look, sometimes people will ring us and maybe it's an employment issue, there's an issue about that. But those we try and direct and guide and explain, you know, that needs to be dealt with through a different route. We're confident that the figures we've given you fall within the remit of what would consider whistleblowing. As where people think there's people coming to harm, it may be for an individual resident, it may be a number of residents. Would it always result in an inspection? Not necessarily, but it will also always result in a follow-up or inquiry. And that'll mean contacting the organisation, the care home, for example. It may mean us following up, it may mean us doing another inspection. Particularly in care homes, I mean, possibly one of the reasons why the numbers of whistleblowing are greater with us in care homes is back to the point Christine made earlier. They're all registered with us. They're required to register with us. There's 470 of them. They would know their inspectors. They would know RQIA pretty well, as would many of the families. I suspect we're less well known in the HSC sector. You know, our role as an inspector is possibly known, whether our broader role for improvement and so on is as well known. So it may be that it's simply down to proportionality, the fact that all those homes are registered, maybe that in itself, and they're familiar with us. But it doesn't alarm us, and in fact we use in this opportunity and others to continue to raise awareness of our role, that we will investigate whistleblowing issues. People are offered anonymity, protections, as far as is practical and possible. But our driving force in looking into those sorts of issues is patient safety. So we always qualify, we will make every effort we possibly can, but patient safety is a dominant factor.
And are you concerned about those figures? It was just in the stats, so that's 10% of care. If each whistleblowing is about in one care home, that's 10% of those registered, or is it? Are there themes and patterns within them? It's a concerning number to me.
Yes, I know.
Given the history with Donaghy and other care homes, it is.
Yeah. It depends which way you look at it, because RQIA does depend very much on getting information in from the public, and one of the channels by which that can happen is through whistleblowing. So actually, hooray, people do come to us and do raise their concerns, and I think that's very valuable. So I'm not unduly worried about the number. What I am worried about, in a sense, is, are we actually getting enough? Do enough people know about our role? Do they realise they could do this? Because when the information arrives in with us, if I can pick up on that, we log that first and foremost. It goes to the team responsible. They examine it. They see what other information there may be that we already have from somewhere else. Because one person saying something about a care home, well, you're a bit of a quandary as to how much weight to attach to that. But if you find there's 5, or if you find there's 15, that then goes into our mill professionally within RQIA, where a team will look at that and go, hey, we need to do something here. So there is that exercise of judgment, but we very much welcome those concerns, and know the fact that we have them, I think, is to be welcomed, actually. Really, we could do with more. I say that, but I mean, not in that sort of way, but I would like to be sure that anybody that wants to raise a concern doesn't haver, that, if they think there's something not right, they feel they know they can come to us, and we will look at it rigorously, robustly, properly. We will add into it the other information that we may have, and we will act. And I think that's the really important point. We will act because we have the powers to act. It's not, just talking into a vacuum. Our inspectors can go out and do an inspection in a care home. We can, if it's about a trust, we can raise those concerns. We can decide. We will go and look at, investigate.
The scale can be quite different too in different cases. I mean, we reported earlier this year on a case which is in the domain where we had whistleblowing in one particular facility, and RQIA led a multi-agency investigation into that. And, so there's one whistleblowing that led to quite considerable and good actions taken, and indeed the provider working with us and addressing the issues that were raised. That's quite substantial amount of effort from a whole range of agencies. In other cases, it could be member staff raising something with us about access to, activities or nutritional issues, or, the scales can be quite different, but they're all valuable.
Okay.
Thanks, Donaghy.
Thank you, Chair, and thanks for this. Sort of answered quite a few of the areas that I was hoping to probe. As somebody who's been on the other side of a RQA investigation, I know how thorough you are, and it's great, because at the end of the day, it's about patient safety, and particularly in the care homes, it's about safety in homes and vulnerable people, as Mila said. So it's important that that those standards are kept very, very high. Can I ask just about the homes, the accountability, how close you are to those homes, particularly when it's like a chain who have multiple homes, and there may be multiple failures within homes that are owned by one particular provider. Do you keep records of that? Is that something that you would look closely at, that there may be an organisational issue there?
Me too.
You take that, Briege.
Well, yes is the short answer, but I would like to qualify that a little bit, if you don't mind. Because of the way the legislation in Northern Ireland is, each home, even though they may be part of a group or a chain, I think as you mentioned, or a group of homes, they register with us individually. So every home is individually registered, each pays their own fee, etc., etc. Now, a responsible individual for a home could also be a responsible individual for another home, and so on. And when the homes register, we do record if they are maybe a single home run by a family or a family organisation or something like that, or indeed if they're part of groups. So we do have a record of homes being connected. But the inspections are individual, the reports are individuals. I mean, each home has its own care home manager. It's the manager's name and the responsible individuals whose names are on the certificate inside the front door. It's they who are responsible for that home. So all of the legislation works around that individuality. Now, we are aware of groups of homes, and so when we come across serious issues or issues of concern, we would of course consider, is that something that maybe is present, across that group? But it depends on the nature of the issue. Homes are personal spaces, they're individual homes. They quite often, most often, have their own individual characteristics, despite being part of a chain. But where you're looking at policy issues, culture, all of those sorts of things, we do stand back and look to see might there be others, and speak with those who are in charge of those homes, ordinarily who welcome RQIA's input most usually. But there is a difference in Northern Ireland than England. And that, now, I don't have a huge amount of knowledge on it, but I know in speaking with colleagues in the regulator in England, there is legislation there that actually permits conscious oversight of groups of homes because of the fear and concern of a group, for example, if they got into difficulty, the potential for that to affect a very large number of care homes. So there is actually legislation in England. I'm just afraid of quoting the actual legislation in case I get it wrong.
I can't help you read.
But it would be something, I think, worth considering. When Christine mentioned that we understand the department are going to take forward, we hope with all of our involvement, this review of RQIA, and no doubt considering the scope and scale that we have. So it's an area I think could be, yes, we do it at a sort of a very practical level, just an oversight level, but we don't have any particular legislation or powers to allow us to look at groups of homes.
It's quite interesting. That's exactly where I was going with that, because we are seeing these bigger groups of homes that own multiple sites, and if you do see repeated incidents, it would be a cause for concern, I think, and I think it would be something that you should be able to look at.
Yeah.
Do you have any powers that you can recommend people or organisations that maybe shouldn't be involved in getting contracts or running homes, or is that?
As I say, the legislation is very much about individual. The way it was written probably 25 years ago, it considers each individual establishment, much to the frustration sometimes of providers, because, for example, we will do fit person interviews and what have you with each individual organisation, and they'll be thinking, why can you not just transfer that from there to there to there? No, you're a registered establishment in your own right. You're responsible for what goes on inside these four walls or in this service. The responsibilities are not transferable.
Certainly, as an improvement, you think it would be something that possibly we should be looking at in future, that we should have a wider view over that? That
idea, certainly. I don't know if England, I mean, I think they have produced, evaluation or audit of it, but it's part of their remit, and it's accepted by providers that their group performance, group financial position, etc., will be assessed and will be examined. That's not the case, to the best of my knowledge, in Northern Ireland.
That was my next question. In terms of financial powers, what powers do you have to look into the financial stability of what are effectively people's homes? If something happens financially to that group or to that home, people end up getting removed from what is their home. Yeah. So what powers do you have in relation to that?
Yes, you take that, and I will chip in about Ballymena later.
That would be helpful. Look, financial management in any establishment is part of good governance. At the very outset, when an organisation registers with us, the first thing they have to do is establish that they've got a sound financial basis. And so there's steps taken at the very outset that this organisation and this individual who's putting themselves forward as a responsible individual has sound financial standing. We have one finance inspector in RQIA, so that gives you the scale of things. And his or her role is certainly to examine those sorts of new applications, but also on a regular period examine some of the financial aspects that are available in each of the care homes or other establishments. That recent example I was mentioning to you, for example, about the whistleblowing that led to us looking at a service engaging with other agencies, one of the significant parts of that was the financial position of the organisation. And so we liaised with the Belfast Trust, internal audit, the housing executive and others to examine the financial. The organisation provided us to us all of their accounts, returns, so those are all available to us. RQIA can ask for any information it requires to allow it to carry out its functions. Financial, CCTV, I understand, all sorts, any evidence that's required. And the interesting thing about that is that organisations are compelled to provide it. So we must, it's one of the reasons Christine, I think, mentioned earlier about, whilst we do, acknowledge the value of management consultants in undertaking pieces of work and so on, they don't have the powers of regulation to compel the availability of information, nor to take actions beyond that, should that be necessary. But to give you an example, there's a situation where the financial position and the management of patients' money and of the organisation's money, its reserves, all of those things were examined as part of that investigation. And we can access all of that information on request.
Thank you. That's very good to hear. That does sound quite wide-ranging, and hopefully that can be built on then as well. One last question. The Chair doesn't mind just building on something the Chair said he'd get in before me. He tends to do that. But just in relation to the fees, so you get 9 million a year from the Department and 1 million a year from fees, but the fees haven't changed since 2005. So why was that? And how much have you lost? What's the?
I'll leave that one to Chair.
I don't quite know why, because I live in the countryside. I have a septic tank. I had to apply for a discharge consent form because one hadn't been put in place ages ago. I had to pay £200 and something for this form, and because I'm on their list as having applied for this, I got a nice little text from the Department of Agriculture to say, by the way, the fee's just gone up. We've examined with inflation. If you're still pursuing this, you need to pay £200 and something, automatic uplift in lieu of it. But that mechanism isn't built into our fees. So my understanding is that the fees were set in 2005 at a rate which even in 2005 did not cover cost, and they've not been touched since. To me, it's wrong, because I do think that where independent sector are providing something, and part of their ability to provide it, the licence, is the regulation, they should be paying for that. I mean, it just horrifies me that it's not. Why it's not, I don't know. I do know that the department are now fully seized, I think is probably the civil service language, of the issue, and are looking to see how they could prioritise that. But it is actually, when you come down to it, it's quite a complicated piece of work, because you can't charge more than the cost of regulation. So you have to be able to work out what the cost actually is. We've done a piece of work, an initial piece of work, on how you would go about calculating the right amount to charge. And then beyond that, there would obviously be a process of talking to the providers and saying, by the way, this is coming. Start factoring this into your business cases and so forth. But I think that is starting to move now, and I very much hope it'll reach fruition as soon as possible. I think it'll have to be part of a managed process, though. I think it would be very difficult just to go from 2005 level of fees to 2025 level of fees in one jump. And Then there's also the whole issue around independent healthcare and the fees that we're charging or not charging for independent healthcare providers. I mean, fees largely is social care side, care homes, but the independent healthcare sector is sitting there as well, and their fees are similarly 2005 levels, and this whole scope and scale is just completely different. So it's a big exercise.
I mean, the committee wrote after our last conversation a number of months ago to the department in relation to the issue of fees, so they did respond to say it was part of that ongoing work. But you're quite right. I mean, I would certainly hope your staff aren't being paid what they were being paid in 2005, because they would be.
If I had my rates bill still at 2005, I'd be very, very happy.
Okay, moving on. Linda?
Thank you, Chair. I was just going to say actually that this is not news to the Department or the Minister. I think I've been raising it since the first time I met you, which I can't even remember now how many years ago that is. And I'm quite sure plenty of people were raising it long before that, including yourselves. So, I mean, it's all right saying, you know, we're aware of it, it's a significant piece of work, but they just need to get on with it and do it. And I'm going to go into another area that I'm asking you, because you're saying, you know, we can't charge more than what regulation would cost, but I'm quite sure that's highly unlikely to happen, because what you actually would do is you would do more regulation. That's the reality. If you had more money, you would do more regulation. You would widen the service that you provide and the oversight that you provide. So just a quick question in relation to the non-surgical cosmetic industry. So I have some concerns, not just in terms of the oversight, but just the fact that we don't even have proper regulation to start with. So what would you regulate? But are there any conversations with the department, and if there were, and if you were resourced to do so, would you be, or could you be, the right body to oversee that that area? I'm just, because I'm not even sure that it would be something that you could or would do, but if it was properly regulated, because that has to be the starting point, because actually it's not, I don't know how you'd regulate it at the minute, because there aren't, I don't think there's
nothing there. No, I think this is, and one of the problems here is the way that our legislation currently is crafted isn't really on a well, to me, isn't on a very logical or consistent basis. If you look at the legislation in England, it's very much focused on services, things that you have done to you. So, you know, if you get needles poked into you, that's something that in England I think can be regulated, because poking needles into you is a service that can be regulated. Here, whether or not something's regulated depends not only on what the service is, but on who is delivering it. Yeah. So the one that to me is absolutely lunatic is oxygen therapy, where if there's a doctor involved in the provision of bariatric chambers or whatever they're called, that has to be regulated by us. But if I go out, Christine Collins, not a doctor, start getting some oxygen cylinders and giving people oxygen, that's fine. No regulation required at all.
I'm not sure that's how oxygen chambers work.
Just as well,
just to clarify,
but I do get it, and I think actually, to be fair to you, you have explained this to us before. I think just based on that, Chair, we need to be asking the department a number of questions. Firstly, what plans they have to properly regulate non-surgical cosmetics, and then how it would then, what would the oversight or the accountability body around them, and what are the plans to actually introduce legislation that properly allows RQIA to do the job that they're supposed to do, and not just to regulate a specific organisation or person or group of people, but actually what's being done to patients. Because what we're doing here is regulating the provider rather than the safety of the patient, which is not what was the purpose of that.
Yes.
What is the purpose? You know, that seems like madness. We're not actually looking after the patient.
Really welcome your initiative in that. I mean, we've been speaking with other professional regulators just yesterday, for example, at the Joint Regulators Group, about services that aren't registered or regulated in any way. I mean, we're worried about online services, we're worried about pop-up clinics, we're worried about high street services. some of those services are provided by professionals who in themselves are registered with a professional body, and so there's some oversight of that individual's practice, but the service isn't registered. And there are other services provided where the individual is not a registered professional regulated, and it is growing. And we would agree with you, I think, in what you're saying, is that while the legislation remains as it is, it becomes I hate to say this, but like a patchwork quilt of what is regulated and what isn't. Perhaps when the legislation was written 25 or 30 years ago, in those times, services were largely maybe medically driven, doctors were in charge. That's not the case nowadays. But the legislation requires quite a lot of regulation of services where doctors are involved, such as the oxygen that Christine mentions, but not other professionals. They were possibly not envisaged at that time that they would be providing these things, or high street, cosmetics and so on. So we would very much welcome that.
I think we need to see something coming from the department urgently on that, Chair, because here's the reality. The people who are having to fix the problems are being regulated. And they may well not have the experience or the expertise to fix the problems that they're dealing with, because they had no part to play in deciding to do that to somebody in the first place, or putting something into their body that potentially should not have been put into their body. But they're going to be regulated, and they're going to be held accountable if they aren't able to fix the problem. So this is costing our NHS a serious amount of time, money, resource in terms of people, and we need the department to take this seriously. We need the minister to take this seriously. It's a problem, and it's not going to become less of a problem. It's potentially going to become more of a problem. It needs to be done right. So I'm not suggesting that something is done quickly, but they certainly need to be looking at it now and telling us what they are planning, and giving us a programme or a timeline or how they're going to do that. Thank you.
And thank you very much for that very good description of the difference of the shift from patient safety away from focusing on establishment and provider. That's very clear.
Thank you. Alan?
Thanks, Chair. Good to see you again. Welcome back. Danny had complained there of the chair getting on before him, so I'm going to complain about Danny getting on before me with regards to the fees. So, with your permission, Chair, would you maybe allow me to deviate away from maybe the main thrust of this and to the SWAH report? You said, Briege, in your comments to the Chair earlier, that you have been listening very carefully to patient experience, which is good. Now, obviously the report that we have received from SWAH shows that in a different light. They suggest that the review failed to get to the truth of the matter. They go further and they say that they have provided many cases of what they consider clear evidence of patient harm. Very damning. They go further again within the report, saying that they have repeatedly made RQIA aware of specific concerns that have become known to them. And finally, they also say that the failure thus far of RQIA to acknowledge and accommodate patient and staff experience. What do you say to that, given what you said to the Chair, that you have been acknowledging patient experience, where SWAH are contradicting that and saying that's not their experience?
Well, I would suggest that SWAH, I don't think, said we haven't acknowledged. They have said that the scale of it and the approach of it they don't agree with. So they do acknowledge they've raised cases with us, and they may or may not be aware. I don't know, I thought I had made them aware that we have followed up on those cases. And I'm talking particularly here, two parts if you like, since the review, because there's also information provided by SWAH about the review itself. Well, I said at the time of the review and the time we came here in March time, I do look. There's always room to improve. I don't deny that. I'm happy to accept that. And if there are ways in future, if we do more reviews and more inspections, are there broader ways? I can only say that for that particular review, as I said at the time, it was the biggest scale of staff and patient engagement that I am aware of that RQIA have undertaken. Will it ever be adequate to take on board every individual case? Possibly not. But I would suggest the review and the 10 recommendations in it, which was mentioned earlier by Nuala, it's very, very significant. The findings in it are very significant. I can't think of another way to say it. And when we were doing that review, we didn't have a huge amount of data. We made that known at the time. We've discussed it with the Trust and others. So I would suggest that the recommendations that were made, much of that was based on, as mentioned to you earlier, 3 things we look for: experience, data and observation. In that case, patient experience, staff experience and observation played an enormous part in those findings. I mean, those first 2 findings, the urgent recommendations, were based on what we heard staff and patients saying. There wasn't a lot of quantifiable data, statistics, all of that. There was some. But I believe it evidences that we did listen to patients. We did listen to staff. And on the basis of that, we made some very significant, urgent recommendations. Since then, I've continued, and other colleagues, to engage with SWAH, who we have huge respect for. Any group, any community or an individual coming forward takes courage, takes endeavour, and we value the input and the information. We don't always agree on methodology or approach, but we all agree we want patients to be safe as well. So we agree on that fundamental. I think some of the points made in the recent letter from SWAH, I'm only suggesting, I'm sure they will qualify with yourselves, but they're referring to recent meetings, recent times where we have focused in on particular pieces. And I don't share with everybody that I'm meeting, including SOAS or others, information that me or colleagues are liaising with individual families. But we are doing, and that's important. But we need to triangulate, I can't think of another word for it, bring it together with quantifiable information, measurable information, and potentially observed. So those all have to come together. But do I feel that we did a perfect review, or that we, in the current situation, do a perfect engagement with families and staff every day? No, we always need to improve. There's no doubt in my mind about that. So I welcome the respectful challenge, which it is. The messages that are put there are respectful. So I will be reflecting on those, and I'm trying to improve further. Working with PCC, which the paper acknowledges we do regularly. I know it says there that I didn't take PCC's advice. I don't remember not taking PCC's advice, but I will stand to be corrected if that's the case. I'm always happy to take advice, particularly those who have much more expertise than I have. So we're very willing to learn, but I just want to emphasise we are still very mindful of the situation and the anxiety that's created for some communities and groups because of those changes, and possibly others across Northern Ireland. We are sighted on it. We welcome the information people are providing to us. We don't make maybe a big fuss about it or put it in the public domain, but we are working on engaging with appropriate people to get the assurances that are needed.
I ask you there for Briege. They have a request that their correspondence of 29th of July. I don't know, have you responded to that as well?
I noticed that, and I can hardly. I usually do reply, but if Helen and the SOAS team said I didn't, I accept that I mustn't have. So I will reply. But since the 25th of July, I've met SOAS at least once, maybe twice, It may have been that I thought I had covered the answers in the meeting, but if I didn't, I'm very happy to cover them now.
I just asked as well, are you concerned that obviously the recommendation 3, which, I mean, I've read it, where it says patients assessed in SWAH and accepted for admission for the Alton Galvin Surgical Service should be admitted directly to the surgical ward and should not be required to attend or wait within the ED at Alton Galvin. I mean, there's no wriggle room in that, but yet the Trust continues to say that they cannot meet the 100% target on that, and they're currently sitting at a 79% target. Are you concerned at that?
I am. I am concerned. The Trust seem to be concerned. The Minister, I think, when he submitted his report, I don't know what the report will say today, maybe things have changed, but in the last report, which we requested, as Christine says, we don't receive them, but I did request a copy of it, and kindly it was provided to me. But I noticed that the Minister had said that there were still some recommendations outstanding. I don't think he referred to which of those they were. Perhaps that was one of them. But look, there's no way of saying it any other way. Those 2 recommendations were made as urgent recommendations, and they were accepted in full. I'm not disputing that it's difficult to achieve, but it isn't impossible. And I mean, the report itself at the time, the Trust, again, very openly, which we commend them for, said they needed to create 12 additional beds in order to create the space to accommodate the service change. Now, when we were in the review at that time, they had not been able to achieve that, or the equivalent of it through service reform, you know, improving throughputs and what have you, might in itself release some capacity, or sometimes you need to have additional capacity. So I'm not saying that that is the only reason why people are still, if that is the case, I've only seen the report in July, so I don't know what today's situation is, but if people are still, you know, experiencing that second wait in ED, it must be, I would have thought, in part related to the bed capacity, because that was a factor when the review was done. Possibly it's still a factor. I do think it's important these things are addressed. Those recommendations were accepted. And I'm not saying that in a, you know, in an aggressive way. They're accepted because they are the right thing to do. And therefore we need to figure out how to do it. It has to be figured out. It has to be addressed.
Obviously my fear in this, and I suppose it's maybe questions for the department, is, you know, when they refer to clinical priority for an inpatient bed due to severity of illness will always overrule patient hospital of origin. I mean, that's 79% where they're currently sitting at. What is an acceptable level? Do we get to a point where it's 25% and it's acceptable and under the guise of clinical priority? Well, that's where we just have to suck it up and see.
They're 2 different issues. Clinical priority, I don't think anybody would debate with that. You have a group of patients presenting for assessment, admission, whatever. I'm not a clinician, but I think all of us accept there's clinical prioritisation. That is not what that recommendation said. It said, well, you've already been assessed, well, it's already been decided, then you shouldn't wait twice in an ED. And everybody said, that's right. Now, how do we solve that? That has to be solved.
I was actually going to raise that issue as well, because what we'll do in the aftermath of this, because I understand you haven't seen the department's briefing to us in regard to the recommendation, so we will suggest that we forward that on to you. It would be worth then getting your view on some of the recommendations, because that one in particular, I mean, as Alan has said, you were clear, patients who are assessing in the southwest should not be assessed and should not have to wait, and they're saying here it is recognised that there will be exceptions, which isn't exactly what you were saying. So I think that's one of some of the issues which we would really appreciate your commentary on. So we will ask if, I mean, I think it's appropriate that we forward that on. We'll just check that out, but it would be good to get your commentary on that as well. You just have to leave at 5 past, it's now 10 past, so if you're happy enough, we'd just like to thank you very much, and we'll keep the contact going.
Thank you very much indeed.
Thank you very much indeed. Thank you.
Okay, members, so there was a number of suggestions there. I mean, the last suggestion that we get affirmation that we can forward on the department's briefing to RQIA and hear their commentary on it, and also Linda had made a number of suggestions with regard to potential legislation, particularly with regard to the cosmetic industry. So are people content that we follow up on that? Does anybody have any other suggestions? None? Okay. So just moving on then. So the next one is the written briefing from the department with regard to the review of the emergency general surgery at South West Acute Hospital. Can I refer members? It's at page 28. I mean, we've already discussed some of it there. Has anybody any other commentary on it? Nilla?
And yeah, first and foremost, I think it's really important to highlight that from 26% in May 2024, it moved to 79% March this year for bed-to-bed admission. We wanted it needs to be at 100, so I think perhaps one of the questions that we should be asking is what needs to be in place in order for that to happen. Another thing to note as well is the Northern Ireland Ambulance Service, and one of the recommendations was around the provision of more ambulance capacity for the referral pathways in particular. And I don't know if we should hear or perhaps inquire from the ambulance service, because I know this is from the department or the trust, and I don't know if it might be beneficial to hear actually from the ambulance service directly on that. I think a written is probably sufficient at this stage on that, but I think it might be worthwhile kind of comparing their two responses.
Amanda?
Literally the exact same 2 points. So I suppose on the 79%, it's what is if they're saying it can't be 100%, what is an acceptable level, or what is the aspirational level, not even acceptable, as what would you be aspiring to in terms of excuse me, the
I mean, I think Noah has even went further and said, like, what are the blockages? We want 100%.
Yeah, 100%.
What are the blockages?
Yeah, what are the issues?
Because they may write back and say 80% is acceptable.
Which and doesn't give us any greater understanding. So I think you're right, Chair. Actually, yes, we need to ask what are the issues, and then in relation to NIAS, I agree with Nuala. We should be asking NIAS, but we should also be asking them how many private ambulances are currently in use. You know, what is the scale and cost of their involvement to date, and you know, are they operational on a 24/7 basis, or are they just for the kind of planned procedures, you know, 9 to 5? So just to get a sense of that, because I didn't see that anywhere. I think that can be added into what Nuala is asking for in terms of that briefing. So a written briefing would be, because we need to get an understanding of it before somebody comes in front of us, and then we're sitting here with it and we've had an hour to read it and you're trying to come up with a question. So I think if we get the written briefing, we've time to digest that, and then at some point we may want to.
So I think we need to check with the department about, because they've provided us with this, if we can send it on to the RQIA, and also I'd be suggesting then that we ask if we can send it on to SWAH as well, just to get their commentary on it, if people are content with that, if their department are happy. Okay, and we'll follow up on all those other issues with the ambulance service and the department. Okay, moving on then, item number 7 is the recovery health service charges. So we discussed this at a meeting previously. Can I refer members to papers at page 42 of the main pack, where we have the SL5, it's page 45, and also the SR at page 46. There's an EM at page 48. So, as I said, we received the briefing from the department on the 11th September, and we're content with the merits of the policy. So the examiner of statute rules hasn't yet reported on the technical aspects of the SR, so we will be agreeing, if that's what we decide to do, the SR subject to the examiner's report. Can I ask them if members are content with the SR subject to that aspect? Everybody content? Okay.
Great.
So formally I have to get used to agree that the Committee for Health has considered SR 2025-158 Recovery Health Service Charges General Amendment Regulations NI 2025 subject to the Examiner of Statutory Rules report, has no objection to the rule.
Great.
Okay, thank you. Members, we're just going to move on then to correspondence in the pack. So can I refer members just to some items of correspondence. There's an issue with the GP Federation at tab 8. I intend to raise that with the permanent secretary, and I mean a confidential manner, because they've asked us not to go beyond that, but I mean it does raise serious concerns. I don't know if anybody has any other commentary on it. Trying to keep it as confidential as possible.
Yeah. We leave it and wait.
Okay. There's a correspondence from the Oireachtas on page 420 of the main pack. I was going to suggest that the clerk engage with the Oireachtas committee, I mean, in terms of maybe a joint meeting here to discuss how we could take that aspect of work forward, if anybody is happy with that. Okay. Then, I mean, does anybody have any other issues within correspondence they want to raise?
Just with the MUP, response on the minimum pricing.
Yep.
Can I just ask, are we going to have any further events on that? Are we having any further evidence sessions on that? I know there had been some consideration about having people in to discuss evidence.
I think, I mean, it's something that I would be concerned about in terms of the delay. I think, certainly from my point of view, it would be a good piece of legislation that we could bring forward. I would be happy, Danny, if you're suggesting that perhaps we get some departmental officials in to give us a briefing on it, if people are happy with that.
Yep.
Okay. Any other issues?
No.
Intent? Okay, so the correspondence tab, page 58, if everybody then is content with the actions as outlined by the clerk, we'll agree that.
Agreed.
Okay, forward work programme. Can I refer members to the forward draft work programme, page 9? Sorry, tab 9, page 431. Any comments, suggestions, amendments? Can I just suggest that we, in a few weeks, are meeting at the Nikon Centre? The clerk has written out to everybody, so we should just respond if people are available and want tickets, because there's an expense to it. So if you don't want, just let the clerk know. I mean, bear in mind that we will have our committee meeting up there on the Thursday as well. That's a different aspect, but if you wanted to attend some of the other events, just let the clerk know and he can get tickets sorted.
I've missed that email, so I apologise. Okay.
Okay, I'll be sending it back to
Do you mind? Yeah. Sorry. That's my... Oh, I know it's me that's missed it. I'm not suggesting that you didn't send it, believe you me.
Okay, are members content to note the briefings are set out in the forward work programme?
Yes.
Okay,
Right.
thank you. And I think you'll engage with some of our policing board members just in terms of the date that you're not, just for a visit, so that we aren't clashing with a policing board member. So
yeah, we'd agreed that we would hold a meeting down at the SWAH. At the minute we've got it scheduled for the end of November, but I'm conscious we've now, I think we've 4 members on the policing board, so it'd be good to know sort of the schedule. So it is just to see if there was a week that would be better suited, I suppose. But I'm happy to have a chat with you.
To be fair, we're probably all on different committees, so it's going to be
Right.
impossible for you to work out a Thursday that suits us. So we're just going to have to work out what time would the meeting be at if it's in SWAH? I
meeting
know
would be
obviously
in-
we still have to
in
make it
the
from policing
afternoon.
board to.
The plan, and discuss this with the chair and deputy chair, is we would try and generally when we do a meeting like that, we'll try and put something in the morning as well.
Okay.
So the plan was to maybe try and do a bit of a business breakfast with local businesses and council around the issue, and then do a tour of the SWAH and then have the meeting. So it is, so the meeting would be at the usual time of 2. We can push it back a wee bit if it helped members.
No, I don't want to interfere with times and stuff or anything actually, because we won't know until we see what's coming up in the policing board whether we're going to be able to move it around. So I think it's unfair to expect you to change it. I think you should go with it. I know the one thing you do need to know is if you're going to be court.
absolutely. Oh, well, they'll do about
It sounds weird, but if you can have something on the 5th Thursday of the month, if there's a 5th Thursday, that's brilliant, because all
Some
the
months
meetings
there are.
are on the 1st, 2nd, 3rd and 4th. But that odd month where there's a 5th
I thought you were being
Thursday would be
sarcastic
great.
there, Colin.
Some of them, there should be 2 months in the year that have 5
There is a fifth
Thursdays,
month,
so
fifth
they're definitely the ones to stack
Maybe
up.
wait until then.
We'll take that very vital piece of information which I thought you were joking about. Okay, so members, we are now, the Permanent Secretary is not going to be here to 3:30, so I'm going to suggest we just take a bit of a comfort break. What we're saying. Okay, everybody, we're at item number 10, which is an oral briefing from the department, obviously the Permanent Secretary. So can I refer members to your papers, tab 10, page 438 of the main pack. And can I welcome Mike Farrar, Interim Permanent Secretary, the Department of Health, Jim Wilkinson, Deputy Secretary, Healthcare and Policy Group within the department, and Tracey McCaig, Chief Operating Officer, Strategic Planning. So you are all very welcome, and thank you for coming. So you have sent us the reset plan and the business plan. So I'm going to hand over to you, Mike, just for some introductory remarks, and then we'll go straight to questions.
Okay, well I'll try and keep the opening remarks really quick, and then we can get into questions. Just the last time I was here, I talked to you a bit about how I was kind of seeing on that and the need to reset our system, and I said we were going to publish the plan, so obviously we've done that. The things in there that you would, I think, hopefully be able to support, and you can see where they are. The proof of the pudding is always in the implementation, and I know that you'll ask me about that, but in essence, we're putting more emphasis on prevention, both primary and secondary prevention, so keeping people well, and then when they do need help, responding very quickly. We've described in there what we have called neighbourhood health, and that is very consistent with, I think, most health systems in the world are trying to get to people earlier and standardise the care that you get and make sure it's high. We're looking at those pathways now being delivered in an evidence-based way where people do need secondary care, and we feel that things like GIRF points out a number of areas where we can do better and get more productivity in that space. And then using the data that we've got, which is a great asset for Northern Ireland, to be able to understand really where you need to target the efforts and focus our priorities. And we might say more about that in due course, about thinking about what signals are we going to send to the HSC and indeed the people of Northern Ireland over the 3 years when we get our settlement about our priorities. Because in a sense we haven't really been as clear as we might be or want to be about what the priorities for expenditure are. In there we've also talked about life sciences. I've just come from a meeting with a large number of potential funding bodies about really opening up Northern Ireland system to be very much more innovative, much more quickly, and that will bring with it, I think, financial benefit. And then crucially alongside that, looking at efficiency. And what I've been trying to say is it's not a very sensible strategy for Northern Ireland to just assume that we can carry on at the pace we've been going, increasing the money. Now, that's flatlined since 2022, but you know, if you took the overall trend, it's still going up at the expense of things like education, transport, housing, environment, community cohesion, which obviously will impact on the wider determinants of health. So trying to really get better value out of our spend, and a couple of things that we're doing that are useful for yourselves and we're happy to answer questions on are, we have now a weekly system financial management group that looks at all our expenditure across the whole system. You know, we have Department of Finance with us on that, and indeed the audit office come to meetings if they want to, so an open access, so they can come along and look at that. And we are looking to make our savings, you know, and no doubt we'll want to ask about the fact that on the pay element of that, which is 200 million, we're asking for support on that, and I know there's ongoing dialogue about that. We are absolutely trying to change the way that we work, and some of the reasons why we've not got things over the line previously has been that perhaps we've not had some of the cultural things in place that we need. And just to give you 2 or 3 that I think we're focusing most on, operating as one team. I know that sounds really common sense, but sometimes we haven't quite operated that way, and we do that now. Getting our clinicians to lead on some of our general management challenges rather than just feel their jobs to do the one patient in front of them. and the idea that we sort of devolve some of the decision making, which has by default ended up at Stormont really, and really empower our trust locally to be accountable for, but to take some of those decisions much closer to the patient. And I think that brings with it a richness of good decision making, but it also puts the responsibility in the right place. So we're trying to change the operating model. So look, we're having to deal, as you might imagine, when you turn over stones to try and reset, you do find things that need fixing in the short term. But we've tried to set out that longer term vision. And I believe that, this is a 3-year, this isn't a 10-year, as England is saying. In 3 years, it would be nice if we had a little bit more resource to actually oil the wheels of change, but not to continue to spend money that should be spent in other areas. So we are, I'm as always optimistic. I've got a lot of support for the vision, for the reset. Although there's a lot to do and we start behind the curve compared to England, Scotland and Wales on some things, there's no reason to believe that we can't leapfrog and be in better shape. So that's quite optimistic. I could have pulled out some of the things that are more challenging, like our financial ability to meet the pay award this year, etc. And we have some quality issues that we're dealing with, but every one of those gives us an opportunity to think about how could you avoid that going forward whilst trying to deal with it in the short term. So I'll leave it at that, if that's okay, Chair.
Thank you. And I promise, with the exception of my first question, they will all be relevant to the reset plan. I just wanted to raise the issue of capital projects and capital builds. It's in the news today. Obviously, I looked at the department budget, draft budget, and there are 14 projects within the department under that 79.2 million, which are saying they're under the headline of contractual commitments. Projects that are reasonably well advanced or contracts are signed. So the Children's Unit at Dalton and Galvin is one of those 14, and yet we're hearing in the news today that there's been a decision to halt that, and the department haven't commented on it. So can I ask, in relation to that decision, specifically, when that decision was taken, when another decision will be taken about whether that project goes on ahead, and then with regard to the other 14 projects that are listed under that heading, has similar decisions been made? Because, for example, Birch Hill and Antrim, I would have been concerned in terms of following up. All of them are very important. So just some assessment about these other 14 projects, where they're at, and the way forward with regard to capital projects.
If I start at the general point, Tracey might want to come in on that. The issue for us is we're having to look at every pound that we've got. As you know, in the past, and this has been consistent across the NHS for about the last 10 years, and we've been no different, capital has been used sometimes to support revenue and resource problems. So we've been looking at, is that something that we need to bear in mind? And so, in a sense, there's a constant review of our capital programme going forward. We've been asked to put forward our proposals into an even bigger sort of set of planning around Northern Ireland footprint and what capital allocations there might be for health in the longer term. Ideally, that might have been a 10-year sort of plan for capital, and we know that ISNI hasn't quite got there yet, so that's the wider government piece. So what we're having to do really is to look at all our capital programme and say, what is the cost of any sort of delay versus what we might be able to offer as an opportunity for supporting resource use. And that might be because it's bartered between government departments who might need more capital but have resource to spend across with us. And so that's really why there has been some scrutiny of those things. And we're looking at those on a case-by-case basis.
Yeah, and just to add to that, so there's no firm decision on all, but at the minute they are all sort of on the list of a pause, if you like, so that we can get a chance to have that conversation about whether we have opportunities to have a surplus in capital, which will help us manage our revenue position, or whether indeed that going into the future with the next 3-year budget plan that we might have, the revenue consequences coming along with those capital schemes, whether indeed the two things match. every one of those projects are on the list because they are priorities and we would want to support them. There's none of them that we would wish not to support. But the reality that we're facing at the moment means that we just have to take a moment to have a look at them. So that's the position now. So there's no firm stamp on any, and certainly at this point we have raised all of the plans that we're saying, if we didn't proceed at the speed that we planned to progress, what would that do? So it's all in the modelling of that. And I know that that's very disappointing. We've had lots of challenging conversations. They're there because we need them and want them. But its ability of whether we can afford them with the projected numbers coming into the department is a challenge for us, both on capital and on our resource side.
So I'm just a wee bit confused because I'm reading your own draft budget, and it's saying under this contractual commitments are inescapable and reflect amount we are obliged to pay to ensure the projects are delivered to the agreed completion date. And what you seem to be saying to me now is that isn't the case.
I'm not commenting on specific because I literally heard about it when I walked in the door just into Stormont today, so I'll have to check that one out specifically.
Okay.
But on general principles,
This is referring to all 14 of these projects. That's what I mean. There's a list of
those were a lot of those. For example, Birch Hill would have been classed. There would have been a contractual commitment to the design principles, but it wouldn't necessarily have a contractual commitment to the rest of it. So it's maybe just in how it's been expressed in that. So I've used that one as an example. I know specifically. So where we haven't had a contractual commitment, they would have been classed to us as partially committed, and we might have had to re-looked at those. So those have been a category of partials. But I can't give you every specific one. I don't have that with me just today, but we can provide an update.
Okay, and I'm just trying to paraphrase. I don't want to paraphrase what you're saying, but what you're saying is in the budget there was 80 million set aside for these particular projects, which you may now no longer spend on these particular projects, and you may be diverting that money to revenue costs.
We are looking at the options as to whether that's even something that could be done and exploring that with the Department of Finance to manage the fact that we are overspending and that we are going to have to make some decisions about how we do that. That might mean a slight delay or deferral of a scheme on that list if we do not have a contractual commitment.
And I should say as well that there is no promise that we've had that there is a capital to revenue transfer available to us. But in the situation that we're in on the revenue front, we felt it prudent to look at those where we're not going to incur additional cost, if you like, but to look at whether or not there is a possibility of making that available. To give the committee a sense of what scale of that would be, that would be around 25 to 30 of the 80 that could be potentially in that space for, if it was available, a capital to revenue transfer would be fit. So not that there isn't any capital expenditure, there is, but that's the kind of scale potentially that we could use. In the event that we get certainty that that's not a facility available, at the 6-month stage, I asked everybody, could you make sure that we wouldn't lose that resource if we don't have a cap rev transfer? In other words, we would still be able to spend up to the maximum of the 80, and I was assured that would be the case. So we're not in danger of losing money, but we're reviewing those schemes, and we have around £30 million worth of schemes that are in our sights to say, would it be possible for those schemes to contribute to our revenue problem as a short-term thing. And again, that isn't to say that we have ruled out any of those schemes for long-term development and support.
Okay, so it's welcome to hear that they haven't been ruled out. When, in the Western Trust case this morning, when will we hear that the Children's Hospital in Donaghy is likely to proceed? And will it be the same date for all of the projects?
I think what we're outlining now is that we're in a kind of an evolving situation with the financials. We're going to have to watch what way this plays over the next month to see where we project out to the end of the year, whether the opportunity's there. Now, on the Donaghy one, I need to go back and specifically review it, so any of my comments are general at this point, because I genuinely only heard as I come in the door and I can't remember the detail of it. But on all of those, we're looking at in the case by case, like Birch Hill you mentioned, certainly the Northern Trust and you know, others are calling constantly on that, but they're in a grip that we're having to say we have to just wait, we have to play every lever into managing the financial position, and we're doing the best we can. Each one of them comes with a future revenue cost. Yeah. So, you know, it's both. it's in year, but it's also about that project it forward with the budget that we are now being sort of advised we will have. So we've had to relook at what our ambitious plans were, and to be clear, we would want all of the schemes. That would be our ambition. We have taken them through very lengthy business case processes and invested significant time in getting them and money to get them to this space.
And that's one of the criticisms that the general public will have, and they will expect us to portray on their behalf as politicians, the fact that the department haven't got a great track record, and putting that mildly, when it comes to capital projects. And as you quite rightly point out, Tracey, with regard to these 14, they're all absolutely necessary. The department have deemed them absolutely necessary, and there's been significant time by staff invested, and outside bodies invested, in significant money. So it would be, it would be probably unacceptable that money and time was wasted, and that these projects that are needed aren't progressed. I'm disappointed that we're not getting some firm answers here today. I think the committee should be furnished.
Well, we can come back on the specifics of that scheme. Okay. I mean, one firm answer I can give you today is that PAC, as you know, has been critical of capital planning generally, and we have put ourselves forward for a review from the department that's kind of supporting that SIB, and so we are open to how can we improve that process and look at some of the schemes that we've had. So I'm hopeful that will help you, because one of the other things that I've noticed, although I can't give you a sort of randomised goal trial sort of statements on this, but I can tell you that I think it's an issue for us, is that the costs of some of our build compared to what I would expect in an English context, beyond what you might say because of labour market supply or whatever, looks high for some of our schemes. And so again, we are prepared to look at that, because if it means we can do more schemes as a result of driving down the cost of some of the schemes, then we're prepared to do that as well. So we've got action to improve our approach, but in terms of specifically on Alton Gavin, and that was something that I was surprised to see, because that hadn't been something that had come through my desk.
Okay, I'll move on then. In terms of you talked, Mike, about preventative health, and that's something I'm certainly absolutely in favour on. So you're saying by October 25 we'll have commenced new dialogue with the public through a new public health programme. This is health, but this is October 25. I haven't heard much about it, so I'm actually not sure the public will have heard. So a bit more detail in terms of that engagement and what's contained within it. That.
So the idea of that, and I'll explain what this is. So what we've done in the past is we've had a lot of fairly sort of traditional public health messaging around 5 a day, units of alcohol, get your exercise in, and to be frank, just giving out information is not very effective as a way forward. And so what you have to do is really communicate with people about what they feel about their own health and what they understand to be normative about their own health. So what we're trying to do here is have a rather different dialogue with them, rather than just go out and preach again and say, please be healthier. The idea of This Is Health is to get people to define in their own terms what health means to them, and then to find a mechanism by which we recognise that if they're taking action to improve their own health, then we can reward them by saying thank you to them, or we can literally connect them to rewards. We haven't ruled out the idea of a reward for actually taking action. That might be vouchers for healthier food or whatever. There might be a way to do that. We're using behavioural science rather than public health, and we just recruited someone who will be working with the Public Health Agency, who is a behavioural scientist. This is someone who was a global behavioural economist for Lululemon. And as I often say, if someone can persuade you to spend £150 on a pair of jogging bottoms, they know how to influence public opinion. And so we've now gone through the process of contracting that individual. We have set up a group which is now pulling together all the key people. We had a round table at Hillsborough Castle that was run by the Patient Client Council, who obviously represent our formal way into the population. And we've actually started to get people in each of our trusts who are connected to this. So a lot of that is process stuff, I appreciate that, but actually we will be trying to use some of that at an early stage to influence our winter plan and to think about how staff come forward for VAC and IM, for example, but it's the beginning of something and we've got to frame it right. So there's work in progress. It's probably not hit the public as yet because it's not a campaign in the same way that you might imagine, but we will be starting to, you know, make sure that that way of working is how we communicate with the public about their own health.
The real living wage for social care workers, be great to get an update on that. It's saying September, I think. So I'm just wondering where we're going to see progress.
At the moment, that's in the same space as pay generally. I've not been able to say to the Minister he can afford that at the moment with the budget that we have and the risk of overspending on his current arrangements. You know, we're making huge inroads in terms of our saving into the 614 million that we've been very consistent with is our sort of figure that we have to get to. And the real living wage, I think, adds around, I think it's 25 million to that. So at the moment, a bit like when the Minister said he was intending to make the pay award, I had to say, well, you'll have to direct me because I don't have the budget to do it. That would be in that space. He's not actually asked me to do that yet, so but that's where I would be in the short term.
So you talked about you're making inroads to 300 million savings targets.
The 600, yeah. 600.
So, I mean, how far off the target are we, and can you give us any indication of where those efficiencies have been found within the department?
Well, I'll let Tracey take that. Yep.
So if we're broadly around the 600, we quote about 614, but if I talk in general terms, maybe a bit easier to follow. So our 600, firstly, it's important to set where those pressures were coming from. So it's our full year effect of last year's pay, our projection for this year's pay, 6.7% increase in the national living wage, which we will give out to domiciliary workers who are not directly employed by ourselves as well, care workers and others. The increase in national insurance, real living wage that we spoke, and then some money for growth and demand and the projected high cost drugs that would be coming through from NICE that we have to pick up. So that's about our 600 million. If we keep it rounded, it's a bit easier. So we have been working through with savings, and what we'd indicated at the beginning is we thought we could get to 300. Now we knew that was going to be very challenging, and we are broadly at that space at the minute. So the first 200 is trusts managing cost containment, changes in skill mix, managing the agency and locum position, and trying to drive out the additional costs of staffing or temporary staffing that are into the system. Now that means changing from agency locum and looking at their rotas to make sure that they're as efficient as they can be in terms of permanent staff or at least temporary directly employed. We've also then had other central savings, and we've had some opportunities, for example, in some of the drugs costs that we would manage within SPPG, and we don't have any direct involvement in how they're set. They come to us from DHSC, so we've had a bit of movement on a couple of things there. June monitoring, 25 million came in, which we also said within our plan that we were expecting to receive, although that's maybe lower than we've had in previous years. In the next 100 million, so that's around about 200, in the next 100 million, that's where our capital revenue, 30 million that we've discussed earlier, has come in. Other savings that we have identified through the Strategic Finance Management Group that Mike has spoken to already, that Department of Finance and other in those types of savings and advancements. That took us to about a 300 shortfall. The next 100 million of that, which would take us to the value, would take us to 400. Pay is broadly 200. So excluding pay, we have to get to 400 million. The next 400 is much more challenging for us, and we are certainly working across all of the budgets, but they are tough decisions now. They're like the capital decisions and many more besides. At this point, we have not made decisions to implement vast range of them. There are meetings ongoing. We will have to assess the impact on service and how far down that 100 we could go without having a very, very serious impact on what we deliver day and daily. But trusts have risen to the challenge, and they have, through this second wave that we've done through Strategic Financial Management Group, we're between 30 and 40 additional million that they've added into the pot that they're trying to drive through at the minute, and I am assured that they're working really hard on that, as well as our own teams within the department. So the 400 is not guaranteed at this point in time, because those are very difficult decisions, and I wouldn't want to rehearse them openly at the minute because we're still working our way through them. That would leave us short on the 400, excluding pay. And pay is 200 of the 600, and that's the position we're in at the moment, which is why real living wage and other things we're having to think, the things that we wouldn't normally want to, but we really are struggling to get ourselves to that break even. But I can assure you that the effort that's been put in behind the scenes is tremendous. To get 200 plus last year was a significant effort. We are pushing much further, and the reality is, when you look at our baseline, that baseline is made up of our staffing, our running costs, of largely hospital-based large units, and those direct drugs and other things that our patients will have. So it's difficult, but we are working our way through the last 100 to get to 400.
Just mention one aspect of that which I think committee should be aware of, is that if you remember the money that was set aside to help us make up progress on the elective care, we had three elements of that. One was red flag and urgent, the other was the additional capacity, and then we had a further sort of 85. Is it 85 that way, or 80? And that was the money that ideally we would have been building more capacity so that we were in a better position on an ongoing basis. And because we've got, I think, good news in terms of what we've been able to do down with the first two chunks of money, and the HSC's kind of stepping up, then effectively we've been able to suggest that 73 of the 80 could go towards our savings. So, but what it does mean is that we haven't been putting that resource into investing for our future, because we have to live within our means. So that was a consequence, but it's not a service reduction. It's being able to hit the programme for government this year, but it doesn't mean to say we'll be able to do that in future years, because the capacity is an issue. We were hoping to build more capacity.
Was my understanding that 80 was part of the 215 that was ring-fenced?
That bit was set up as a slightly different, I think the phrase we're getting told is earmarked, okay, which means that ideally it would have gone on that, but it is not ring-fenced in the same way as the other two were. So, and again, that's something which the Department of Finance have been aware of in our savings plans, that we were going to do that.
Okay, I'm sure other members will delve deeper into some of that. Just the last point I wanted to ask on was on the new neighbourhood models, which the Department are keen to implement. From my point of view, they seem to be heavily reliant on GPs, and there's obviously this fraction between GPs currently and the department or the minister. I mean, we've got correspondence today alerting us to the fact that, you know, there's 8 GP services on the. I mean, I don't want to put words into their mouth, but in a serious condition, and I'm sure that could be reflective across. So, I mean, the department having plans is really good, and we do need to reset and change moving forward, but you obviously need to buy in and co-design with pharmacies, GPs, dentists, etc., and all of those sectors. Particularly GPs are telling us they are currently in crisis, and they're in crisis because of the funding arrangements within the department. So I'm just looking to see if you can give us any kind of update on how negotiations are going, particularly with GPs moving forward, and then how that feeds into the neighbourhood model.
So what we are, I mean, you're right to talk about the importance of GPs to that, and I think GPs have got an opportunity to lead the neighbourhood model. I think it's not the way they're working now, though, because at the moment they're doing work which could be done by community pharmacists or by patient groups. They're doing work which they shouldn't be managing. It should be going into secondary care. And where you look at the best models of primary care, which I've been talking to the Royal College about and the BMA when they'll talk to us, is to say that primary care on the basis of a small practice is very chaotic, as in you don't know what's coming through the door. When you start to get scale, you can be highly predictable about what's going to come through the door. Urgent care, elective care, planned care, and preventive care. And so you can start manage the GP workload. You can also, if you're employing and working with a pharmacist better, about 35 to 40% of what GPs are dealing with currently could be dealt with by a pharmacist. And a lot of them will have pharmacists because we've been supporting them to have those pharmacists in place. And like I say, if we bring people out of hospital, these are consultants who are in medical specialties to be more available. And in fact, if you ask Frances O'Hagan, she will tell you how much she enjoys the paediatric support she gets in our advice and guidance model, and says that's made a huge difference to her having to use hospitals to care for her patients who are children and families. So this model is different to the one we've got. And one of the risks that we have is that what the GPs have asked for is more money for the same. And I'm saying I'm really happy to look at the business case to spend more money. In fact, this requires us to spend more money as a percentage in the neighbourhood. Right, and just to give you a sense of that, if 2% of the money that our hospitals are currently spending on services where people have to go to hospital rather than people could get it close to home, that's worth about £160 million, right? So, but that would be money available to put a range of services around the neighbourhood, bringing in community pharmacy, voluntary groups, GPs, social care, local government, which is another big factor there, and trusts, to provide better service. I offered, and I was slightly disappointed that after a letter had gone asking them to look at a new contract with us for the future, that they went into the press, which was sad, saying we haven't had that. Well, I could prove, but I don't want to go into that. So there is a real opportunity for us to talk to them about the future and investing in a model which I think would be better in terms of GP workload, it would be better in terms of patient care, and it would solve a lot of the financial issues which some of the people have got. I'm very sad that we're in the position that we're in with them, and we, myself, and I would say the Minister is absolutely party to this, have an open door to come and talk to us about what we could do. But I don't think it serves the population of Northern Ireland to put more money. I was with the Royal College of GPs recently. We had a very good conversation. We have GPs through their federations who are engaged with us in terms of talking about the neighbourhood model. I would love it if the BMA came back. And just one final observation, which is that in 2002, when I negotiated the move from fee for service to population health, which when we updated the contract, GPs were saying to me, this is all wrong. We shouldn't be putting money into a new way of working, the population health management approach. Just give us more for fee for service, because GP numbers were starting to decline. When we eventually got to the end of that negotiation, we had 83% support in favour from the GPs. They got more money. It's the only time in NHS history where there was a higher percentage of growth funding went into primary care than went into secondary care. As I say, 83% support, and patients benefited because we had a population approach. So I'm just hopeful that GPs will have some faith that actually we do want to put more money into general practice. We do see them as the heart of the neighbourhood. We'd love to co-design the neighbourhood with them, but at the moment they are not wanting to play. So they wanted to stand and say, no, you can't do that. And when I've asked, what do you want from your 80 million, the biggest thing that I get back is more GPs. Well, I'll just give you the figures for how many GPs we have per head of population. So we have 71 GPs per 100,000 population in Northern Ireland. In Wales, it's 64.5 per 100,000 population. In England, it's 59. So more GPs, and even if I agreed that we do need more GPs over time, because I believe in the role of a specialist generalist, I think that's part of our vision. You know, generalism helping people avoid the cost of specialism and stop taking one chunk of them and think you can do that. If we were able to do that, you can't get GPs in overnight, because, you know, so I'm really struggling, Chair, to sort of do things in a sense where I would love to have that conversation with them. We are very committed to opening negotiations and to look at funding streams into general practice for next year. But I'll come back to it. I don't think it serves the population of Northern Ireland to put more money into the same system that we've got as opposed to investing a new way of working. And my last comment on this, and it'll go on record, it's never been on record before, but in 2002, I had money set aside in the contract negotiations to give GPs a sabbatical. Because when you become a principal GP around 28, 29, you then face maybe 40 years of a career that looks fairly similar. And I said, well, why don't we, every 5 years, why don't we give GPs the opportunity to have 6 months doing research or training management, or even have a break, which would be unpaid, the others would be paid. And I said, please, can we do that? And at the very last minute, the GPs came back and said, we'd like that money taken away from that and put onto a quaff point so we get more in take-home pay, because we think that's an issue for us. And I don't want to make that mistake again where we feel that in order to manage the short term, we've put money into the wrong thing, because I absolutely guarantee you that if we had a sabbatical for GPs, their morale would go up, they would be happier, we would keep them for longer, and we'd have more people attracted to work in general practice, which is something that we need to do. So I'll just, sorry, you put me on my hobby horse. We're in a poor place. I don't want to be. I'm a great friend of GPs. I'm an honorary fellow of the Royal College of General Practice. The door is open, and I'm very, very happy to talk to them. And I think, to be frank, I think we would be proved right that over the course of the next 3-year settlement, which we get, more resources will be going into general practice for a different way of working. So that's all I can say, really.
If I was a member of the public listening, I would be a bit disconcerted just with that. And I mean, I'm not, because even the Minister, in terms of everything that the Minister is outlining in the floor of the Assembly about shift left, GPs are vitally important to that. I mean, the public, their first point of contact with the health service. So this is a scenario situation that absolutely we need to resolve. And I mean, not making a political point about who's responsible, but certainly the Minister's statement in the Assembly that has ended the contract negotiations, I think didn't do any good in terms of the mood of the GPs with regard to the department. But I mean, it is absolutely, from a health committee's point of view, it's something that we want to see resolved, because it's absolutely and vitally important for every other aspect of our health service that we have GPs that are not handing back GP practices that are open and access where our population can get it. So I mean, whatever way it needs to be resolved, it needs to be resolved.
I take the point, but I would also ask the health committee to think, what would you want us to invest our money in, if in terms of primary care and the neighbourhood model going forward, as opposed to what we have now. So I would ask you to look at the evidence about what primary care will be in the future. And I think, from just at the point on the public appetite around this, if you go on that BBC website that looked at that and said, how hard is it to get an appointment with a GP, I think about 75% of people said it was hard, and 25% said they found it easy. We do have an issue on access to GPs, and the question is the best way to solve that to try and grow the GP workforce over what would take us a longer period of time, or to think about, can we get GPs working together within a sort of neighbourhood arrangement where you go to the right professionals soonest, so when you do need a generalist, a medical generalist, a specialist, we can get to them faster. So, the current system isn't working, but we diagnose the same, we just have a different solution.
And the committee, a couple of weeks ago, have committed to look at that specific question, where we do intend to look.
We would welcome that. We'd really, and I'll come along and I'll back up all my rhetoric with the evidence around where I could take you to places that have gone down a different route, got higher patient satisfaction, better access, and actually are getting better outcomes.
Just to be clear, what we agreed to do was look at the shift left and what it means in terms of the community care. Anyway, I've took up enough time. Colin?
Thank you, Chair. Thank you. Will we pay our nurses the money that they're owed?
I hope so. I've done everything that I possibly can to ask for the money that we need. I also have a duty of an accounting officer, which I have also got to. I don't think I go to jail because I don't think it's a criminal offence, but I think it's a civic offence. But I've had to say, with huge regret, and as you'll see from the Minister's previous statements, regret to him, that at the moment we don't have the money to guarantee that we could afford that.
And what's the process for that then, given that the Finance Minister said the other day that he would hope that it would be sorted out? What do you do as Permanent Secretary for the department that's responsible? What do you actually do if you've got on your to-do list nurses' pay? Well, what does that mean? Does that mean you have meetings with the Department of Finance? Does it mean that you get the Minister a poke and say, get in and talk to that Finance Minister? What's the nuts and bolts of what you need to do?
So you know the process of ministerial direction. That had to go to Finance. Finance said it's too big for it to have to go to the Executive. The Executive have not decided that. And the Executive have been asking both ministers speak constantly about this, and both ministers, the two ministers, the Finance and Health Minister, and they've asked myself and the Permanent Secretary to look at what we could do. Of course, one of the issues is that this has become tied up in not just the nurses' pay awards, but also awards for wider staff groups and the potential financial position of the Assembly, the Executive overall. So it's become a sort of wider conversation, but that's ongoing. I can promise you, I spend an awful lot of time talking to colleagues about what are our options. To do this, but at the moment I can't take away that letter that I said that you can't afford it. I don't have a financial solution as we speak.
We know that there's a monitoring round due in October, but I think it's been pushed back to November. Does this mean there might be a Christmas present for our nurses in here? In that, I mean, is there an opportunity that money could be made available in that monitoring round for nurses to be able to get the pay that they are owed?
I would hope so. I think we can certainly move forward, and as you know, the nurses are potentially balloting, and we absolutely want to avoid any industrial action if we can.
And I think as of today, that's not might be balloting. I think they are balloting. I think they said if there was no agreement by the 30th of September, they would progress to balloting. So we're into the, what feels like for nurses, the annual place of them not getting their money. But I take the hope that you have there. Hope is better than not having hope. So hopefully that November round will bring some money. The other thing I wanted just to ask was about, because there's one bit that I don't get, and it's not that I'm disagreeing with yourselves, it's just something I don't believe in. I don't think our trusts, and I know many of the chief executives, I don't think that they're so inefficient, and some have said to me occasionally, oh, but they are. I don't think they're so inefficient that they're running up and racking up hundreds of millions of pounds of inefficiencies, that if you just click your finger to them and say, do you see, by the 1st of April next year, find me all this money out of your inefficiencies. I do firmly believe that if they have to come up with hundreds of millions of pounds of savings, then amongst that hundreds of millions of pounds of savings, things are not being done that were being done. That to me is a cut. So is there any headlines of the cuts that are actually happening, or is it a case that the trusts are just so inefficient that they can find hundreds of millions of pounds of savings?
I'll let Tracey come in on this. So
I appreciate that's a loaded question, but you saw where it was going.
I'll try and illustrate some of the dynamics of it.
Yeah.
So when we're paying temporary staffing, you're paying at a premium, as you know, compared to if you had that in a substantive post. So there's a whole set of vacancies that we carry. Some of those vacancies, we probably have to say, well, we're going to either delay them or we're not going to need them. We'll try and find better ways of working. And some of them we should fill as best we can because it avoids us having to have temporary labour. So all the time they're looking at that. We're looking at things like sickness absence. What can we do? So we are really low as a system in terms of vaccinem uptake by staff. So going into winter, our vaccinem uptake is nowhere near it should be or could be. And of course, if you haven't been vaccinated, you're more likely to get flu. If you get flu, you're off work. So a lot of the things that we're doing, you wouldn't call them inefficiencies, but they're things we could do better. And then there's other pieces which are about service change. I'll give you an example of that. Ambulances get called to care homes to take older people into hospital. And usually it's because they've fallen or because been dehydrated or whatever. The latest piece of information we had of those people who were taken into hospital, around half of them get admitted. And of those that get admitted, 80% of them are admitted for something which wasn't the cause of the ambulance call out. In other words, once they get in our system, someone says, oh, well, now you're here, we'll do bloods, we'll have a look at that. And, people who worked in the professional know that's what, And so they get bloods and say, oh, well, we'll just have a look at that and we'll keep you with us. Those were conditions that were being managed okay in the care home setting. Now, we might say, well, that's great because that's preventive, that's going to stop a problem down the line. But actually some of that is people who are admitted who probably don't need to be. And so we're trying to look at every area, standardising practice. You go across Northern Ireland, we could show you the data, you've probably got it already and had it. If you look at the same condition for the same person with a level of need, in one trust it might be 3 days length of stay, in another it might be 6 days length of stay. So it's not that we're cutting there, it's that we were saying if you can be as good as the one that's doing the 3 days, we can have 3 days worth of benefit from that, which we can either take out as saving or we can effectively give you more operating capacity to reduce the waiting list further. So there's a whole raft of different things in there. But as Tracey said, when we start to get to beyond, the obvious areas where we're trying to take cuts from central budget and we're asking them to do, our starting position was, can you live within last year's outturn? And again, just for committee, I'm sure you know this, but Agenda for Change pay rates, it's not just the headline pay rate because of incremental growth. Even if we had a pay freeze, the pay bill will go up by around 2% every year. So, there are things that you can't avoid going up. So even whilst we're debating, can we pay the nurses this year, our payroll's gone up by 2%. So how do we offset that? And when you start to get into what could you do to get 600 million out of your budget when we start with that as a budget, as I did, as we did really on sort of middle of April. Even if you say, well, we'll take headcount down, which is where your biggest expenditure goes, you have to make redundancy payments because we'd have to, that would be right and proper. And let's assume they're voluntary for now. I'm not announcing any redundancies, so I don't want to give the wrong impression. But in a voluntary severance arrangement, you would have to pay the redundancy, so you wouldn't get it back in year, so it doesn't help you with your cash planning. It might help us next year to manage our budgets better, but this year, that's why we can't go all the way to get the pay, which is the 200 biggest chunk of that, but we can get as far as we possibly can towards as much without. I think Tracey, you might want to give some examples of what the next 100 would be beyond our 300.
Yes, and I think the illustration is that it's in year, it's within a 12-month, so what you can affect in a 12-month, you're looking at those things that are variable or flexible, or they're demand driven and you just happen to hit a lucky spot and you don't spend as much as you project it to. But on the flexible, it has to be in year. So those are the things we contract for at different levels, which is the unfortunate reason why you often hear the domiciliary with independent sector or care home. It's not because that's the last thing we'd want to touch. I mean, those are the bedrock of how we manage on a day and daily basis, but those are the things you'd have to look at. But within the next 100 million, all of the trusts have come forward and they are looking at some services where they would have to hold a line and not maybe deliver as the same volume as they did before. It could hit into our elective, which we don't want to do. We're already driving into our elective and we've been really successful so far in the first number of months of the year, and we do not want to lose the effort that we've put into this for the people out there who've been waiting for their operations. So it's things like that. It would be reducing more of the headcount because it's our biggest bill. So you've no option in any business. You will look at every single line of your business and you'll say, well, how could I? And that's all of those things. We have not given permission to go there. We are still looking down. We are still trying to avoid all of those things and work our way down through them. But it's been a very different way that we financially planned this year. And we've taken some risks at the front end of the year that we might have waited for at the back end of the year to try and avoid getting ourselves into this. But the next 100 is tough. It's about reductions. It's about holding the line, it's about containment, and it's about, delay. There are all those types of words that we would have in, but we have not given permission for those at this point in time. We've just still sitting with it, trying to work out a very complicated conundrum, which ties with the capital conversation, ties with real living wage, ties with all of those other elements. But our time is short. And we're very, very aware of the pressure in that, and it's going to be a challenge for us. And I, at this point, certainly my conversations with permanent secretaries been, I'm not seeing an easy route. There is no easy route to this one. It's just the scale of it in year, in a 12-month, it's just so big, and that's why the pay conversation is so vital to us. and that's why, absolutely.
Sure. Would it be okay as a committee, can we ask for maybe a breakdown of just where those cost savings are coming from across the, like, it doesn't need to be the individual line right down to it, but you've given us a few examples, but they literally could be saving $500,000 here or $250,000 there. Would there be something that could tell us where those hundreds of millions are being saved?
We could certainly give the breakdown to the 300 million. On the other 100 that we're still debating about, I might have to be a little bit more generous just for the meantime while we finish working our way through them, so that we don't just frighten people of something that we wouldn't maybe take a decision to do, but we can set it out in a way to give you a little bit more information.
Maybe just for a short answer, just rather than a big long, just ambulance service. I mean, I have constituents who, their family members are taking a stroke. They're dialing 999. They're explaining the symptoms. They're being told it's a stroke. It's 6.5 hours. You literally could dispatch an ambulance from Glasgow and it could take a boat over and it could probably get to my constituency quicker than what we're doing at the minute because our ambulances are stuck outside the hospitals and we know what's going on there. But is there a plan? Are we heading towards a 2-hour waiting time? Is that something that's on the horizon as a minimum at least?
We put a lot of effort bringing people together. We looked at the way that London got down to the 45 minute standard, and we're looking to do that. Some of this is logistics, which is not, and some of it is cost, but some of it is logistics. So wherever we possibly can, and so we have said collectively that we were committing to get to that 2-hour standard, and
So what we have at the moment, we had agreed, and we had colleagues from London with us, which it was quite inspirational as to how they actually moved in that space. I don't think that there's any great difference between what they had than what we have. So we've had an agreement across the region at this point that, now remember, not everything, this is not a grow to 4 hours. Those, we don't want anything over 4 hours during September. I'll be writing out to our colleagues across trusts with the results that are being collated at the moment. I suspect there's a couple of sites that have struggled and there's a few that have shown really great progress in that. What we don't want is for those which are at 45 minutes, or the fact we don't want that to get worse in fixing the other problems. So it's about two things: hold the line on what you've done really well. For those that do fall above, bring it down. So it was a 4 hour for September, and we moved to a 3 hour and a 2 hour, so that we get to at least to the least worst position before we head into winter. So we have been keeping a really tight monitor on it, and with our chief executive colleagues on Monday to have a conversation about where we are and where there may need to be a bit more improvement in particular areas. And for example, I can see, Belfast Trust have made a really good push into that at the minute, and that's really helpful to us, from where it's sited and the tertiary services behind it. So.
And one last point, which I think is a very positive thing, is that the Ambulance Trust have made much greater inroads into their sickness absence than we're getting across the board. So they're really trying hard, and that's a really good news.
Thank you to everybody for driving that down. It's really important, especially for rural constituencies and rural representatives around the table, because we hear it regularly about those big long waits, and it's frightening. It's really, really scary. But thank you for that. So thank you, Chair.
Cool. Donaghy.
Thank you, Chair. We tend to get a lot of phone calls after Health Committee from people who've been watching it, and I imagine we're going to get a lot today, particularly from GPs who will have been listening to what you said with some surprise and maybe trepidation. But we'll see where that goes in future. One thing I do want to ask you about is the winter preparedness plan. Now, it's on your deliverables, delivery outcome there 6. We were told initially it was going to come in August, and I think you're named for this, Jim.
I'm Jim, yep.
Initially coming in August, then we were told September. I think the target is
September, and we're not.
September now. The most recent update says it was delayed until September. We're now in October, and there's still no plan. So what can you tell us about that?
The plan, and indeed the conversation that we just had is an integral part of the plan, because part of the plan is looking at ambulance handovers and looking at all aspects of urgent and emergency care. Another part of the plan is actually what we've also touched on, which is vaccine uptake among staff. So the plan is at a well advanced stage, and members will know every year we have our plan. It's at a well advanced stage, and indeed it will be earlier than any previous year. What we're doing in addition this year has been looking at the work that the CNO and CMO have been leading on the phrase big discussion. And effectively what we've done there is, in addition to everything we're doing, ambulance handovers, early discharge, looking at hospital avoidance, looking at vaccine uptake, looking at the public health messaging, we're saying, and again, some of it's been touched on, there is a particular cohort who we really need to look out for this winter, and that is the elderly and the frail. We need to look out for that cohort because we know that cohort is major users of urgent and care services over the winter. We know that that cohort also does not, as their preferred route, is not an ED department, is not the preferred route of attendance to achieve their care. And that came from that big discussion, which, because primary care, GPs are involved in that discussion, because GPs are keen and have the best knowledge about their patients. Secondary care is involved in that, and NIA has been involved in that, and indeed the voluntary and community sector as well as social care. So that is one area where we really want to indicate within this plan, what are we going to do differently, or what can we do differently this year that provides a focus for that cohort, because we believe in that area we can make some differences to the pressures that we get, but not differences that are about ED attendances, differences that are about the best possible urgent care for the way that cohort wants it. So what that's done in terms of timing, which is the key question, is that we hope to publish that winter plan imminently, because those plans and those proposals are coming to a conclusion. I think we've got a bit more work to do to be a bit more specific, so we can be clear with what we will achieve, but also clear in the messaging that needs to go with it to the public. But we certainly will have that published. I think we're working really closely to get it done, but it'll be before the end of October. Get as much pressure from our minister to get it published, and we'll have that with the committee hopefully as soon as it's published.
It was August, it was the end of September, and now you're saying before the end of October. Now you've got it as an amber there on the rag. An amber means some delay, but should be done at the end of this year. You know, the end of this year is the 31st of December. Are you saying that's
our amber for that is should be done with some delay. Our delay is October from September, so it's October from August.
That's not quite an accurate description of where it stands on the rag then.
Yeah, well, it's amber in that it wasn't September, which it said it would be, and it wasn't July, but it will be with delay. The delay, as far as we're looking at the moment, is October. We'll have it in October. So
you're hopefully by the end of October. Now, it was produced last year, I think mid-November.
Yep.
The Royal College of Emergency Medicine said it was too little too late at the time. What's going to be different this year? What are you going to say that will improve? The things you've already mentioned, elderly, vaccine uptakes and things like that. Well, what is going to make the big difference? The main issue, as I see it, is social care. We have a lot of patients who are in hospitals that cannot get out, and that backs up patients in wards who are on corridor beds, A&Es that are full of patients who should be on wards, and then ambulances stacked up outside that can't discharge patients in. Then people at home, as Collins mentioned, waiting for hours and hours for ambulances because they're stacked up outside hospitals. So what in the report is going to build that capacity within the community?
And I'll call on Tracey, but I mean the main point that we're looking at is we will continue to look at all the angles, so that is from ambulance delays right through to early discharge and timely discharge, and that is a constant focus on how you get a discharge, how you move places. But one of the key elements of the big discussion has been what can we do to avoid attendance at ED, avoiding attendance at ED by providing the right care at the right place. And that goes from our ambulance services doing increased work in terms of hear and treat, see and treat. It goes from working closely with our GPs in terms of early engagement, in terms of medical care planning, and it also goes in some of the work we're doing around frailty and falls. So we really are looking at across all the system, but this year we're particularly looking at what can we do for that population and what we can do to help that population stay healthy and meet their care needs in their home. In so doing, you avoid the ED attendance, you avoid the admission, which Mike's talked about, and you avoid the delay in the discharge, as well as that you avoid the deterioration. So that will be one of the key areas. As I
say, we talk to staff, patients and families all the time, and I know the pressures on our health system across the summer have been very, very high. Yeah. They continue. They've had corridor beds, they've had A&E waits, they've had ambulances outside A&Es all summer. So the high pressure that we normally feel in the winter is now felt all year round, including in the summer. So we're now moving into a period of extreme pressure. So, I know there's a lot of apprehension out there. People are very, very concerned. We were told August, we were told September, now you're telling us October. So, we are very concerned to see this plan and to see it implemented so that it will make a difference this year. can I say just a question too? I was at an event today put on by Voipec. It shows you care event. They produced this report about the children's social care reform. So the Ray Jones review. So they've produced this report. Have you seen the report at all?
I've not read it, I have to say. The original report, or I've had
this
two.
is the update. The original report was more than 2 years ago.
Sorry, I haven't seen the update.
So the original report was June 2023.
I've had 2 meetings with Ray.
Okay, so this is more than 2 years since the original report. This is an update. Basically, young people in care with lived experience, giving their impressions of what needs to change within the system. I don't see it in the reset report. Is there any? I know you have a reform section. Is there anything about children's social care services reform?
Yes.
I think we've referenced social care generally in terms of reform, not necessarily picked out the children's bit particularly, but that's not to say that we wouldn't be interested in continuing to progress that. I mean, I think we've done 46 of his recommendations. There's 7 that relate to the agency, setting up the agency, which is perhaps the most controversial in the sense of, Northern Ireland's very proud of its integrated services, and this would be actually disintegrating them. But I know there's commitment to do it. But generally speaking, we've done that. But we are really aware of some of the areas that had we had more resource available would have been a priority for us. We have
increasing numbers of children in care, as I'm sure you know. It's more than 4,000 now. And the trend is growing up. So we have a reform plan here that's more than 2 years old. As you say, there is recommendations there. Some of them are at a very, very early stage. And when they've said that they have been achieved, I know we've had questions in here about that, similarly to the sort of the RAG colour coding. But I would encourage you just to read that report and to act on it. This is a very, very important issue.
Not a problem. Before you stop your area of questioning, you paraphrased my answers on primary care as though that was negative. I just want to put the record straight in terms of I am not at all negative about primary care. I'm a very, very proud fellow of the Royal College of GPs. I support independent contractor status. I support GP federations. We need to actually find a model that will work in everybody's interest, and that's what I'm interested in the conversation. The door is open. Any GPs who are watching who feel that I've misrepresented or misunderstood, I'm very happy to speak to them.
I'll certainly be talking to local GPs, as I'm sure other members will as well, just about their opinions on what we've heard today. Just add one third question, if the chair doesn't mind as well. Just in terms of research, I think it's delivery number 7 in your delivery plan. Can you give us what specific progress has been made on the establishment of the strategic research partnership?
Yes. So we have a coordinating group together, which is basically the 2 PVCs from the universities, pretty much anybody who invests in innovation, either things like City Deal and or sort of technology pots. We have basically written a clear approach which will involve 3 stages. The first is discovery, and we are committed from our last meeting to setting up what we're describing as an academic health partnership, very similar to the ones that you might have in some of the more advanced systems. This will be the universities and ourselves looking at how can we attract in more research, particularly commercial funded research, because it offsets our costs as well. The next area is development, which is bringing in how do you convert ideas, particularly for those areas where we've got spin-outs from our universities, into practice, and how would you decide the priorities there. And to do that, we're looking to expand on Hirani, which we have there, but it's kind of on a bit of a shoestring. And what can we do with Department for Economy around building that capacity to look at these ideas and bring them through? We're also talking to funders, potential funders, who would, if we have oven-ready ideas of new jobs that we could create and new ideas that improve health outcomes, that's what I just came from a seminar where we had a number of funders who are prepared to look at our options and want to fund Northern Ireland. And then finally, the last bit, which is the key to it all, is delivery. And the idea there is to use our committee in common to try and have a single proposal around innovation which can be heard by all the trusts at the same time. So the whole system can actually pick up on an innovation rather than an innovator having to go to 6 separate trusts. They can do that once. And we have an idea which we've not landed on quite yet, but we will, I'm sure, is that each of our trusts would have a research and innovation committee tracking their ability to adopt innovation and to come forward with innovative ideas. So we're creating an ecosystem which I think will be, I did a report for Northern Ireland about 3 years ago called Health and Wealth that went to Economy and Health, and actually it's starting to put in place that effective ecosystem. We're really pleased about the progress we're making. Everybody's on side, and we're already talking to people who are interested in investing in us. So I won't say them now, because if we don't get them over the line, you'll ask me, come back and why didn't we? But there's a number of parties, both private and social investors, who are really interested in putting money in, which can help us alongside our financial position to bring in more resources into Northern Ireland. So we're not just looking for more from the public purse, we're looking to generate jobs and growth in Northern Ireland on the back of health and life sciences.
Okay, thank you.
And just following up, just very briefly before I bring everybody else in, there was an issue of the sharing of secondary data on an all-island basis,
Yes.
which was hindering research
Yeah.
data. And the Minister had given a commitment in the Assembly a while ago that it was something that he thought he was going to
We're
bring
bringing legislation forward.
legislation.
Yeah.
I can't remember when he said it. I think we're in the amber stage now, probably. So it would be worth.
We have the best data. We have the best data platform in the world for research because of the EPIC and the GP information platform. But we have a piece of legislation that is hampering us. It doesn't completely, but it's hampering us. So we need to change that.
Absolutely, and I mean, I think particularly in the sphere of cancer and other issues like it, you know, all Ireland research is something that we can all benefit from in terms of the research, but also, as you say, it can also invest money into
And
it.
having 7 million population rather than a 1.9 million population is very helpful from a research purpose. Even 7 million is too small in some cases.
So,
Can I just make one point? Just on that monitoring diagram, I know we've been talking about the RAG colour coding system there. We've 23 greens that are on track to complete this year. Do you think we're going to get all that? Seriously?
Well, Jim loses his head if none of us.
Yeah, I mean, it's, as you know, a business plan, and this is the challenge that has happened this year. We've adopted a strategic document as a business plan, which puts a new rigour to the delivery of a strategic document. It puts a business plan rigour to it. So that's why we're applying the RAGS days, which you normally wouldn't have seen against strategic commitments. And this is our assessment of where they are from the policy teams who are leading them. Now, I would say you'll find a lot of our greens are in the preparation of guidance. Some of our greens are in the delivery space. Some of them are in the what we'll do to push reform forward to the next stage. So our challenge is, yes, as it stands, the teams are saying they can deliver this within the timescales and commitments they've got. It'll be monitored quarterly because that's the way we do business planning. But the reds that are there are the biggest problems that we're dealing with. You'll see the finance one is there. You'll see a lot of, for example, I think our neighbourhood is in the same space. Our neighbourhood has come up with what is the model for neighbourhood in Northern Ireland, how would it work. The operating environment in which we'll be able to land that into delivery has to take account. We've talked a bit about the challenges with the GPs, and we're working to try and resolve those. We are working to try and resolve contractual issues and deal with matters we can, as well as shape the future. That's the same for elective care as we work to what might happen in the operating environment if we end up in a difficult space with our consultants and with our nursing workforce and with our social care workforce. That will all have impacts on delivery. So it all has to be continually monitored in the context of the operating environment. But as it stands, we've applied the business plan rigour to a strategic document, and that's where we are.
Thank you. Thank you, Chair.
thanks. Linda?
Thank you, Chair. I'm sure it's not your intention, right, but I think if we're talking about a reset, the first thing we probably need to do in relation to the GP issue is a wee bit of a reset in tone, because I understand that your door is open. I don't doubt that. I don't doubt that you're serious about what you want to do here. I'm not questioning any of that, but my door of my office is always open. It's open every day. But if I don't build a relationship and build trust with the people who come through that door, they're not coming to me. They're going to somebody else, and that's okay, because I haven't built that relationship. I haven't invested in them, haven't invested my time in them, and they don't feel that I'm somebody that they can trust with things that matter to them. So that's just a comment. So I'm just throwing it out there, right? You don't need to respond to that. I don't expect you to. I don't doubt your commitment to this. I just think that there does need to be a reset in tone, because the GP saying we want a deal and the department saying we want a deal, and nobody actually coming together to say, you know what, let's work this out. We can work together. I'm for you. I have your back. Let's sit down and have the conversation. So I'm going to leave that there. Just in relation to the children's social services, it is actually in the reform plan, and it's on page 447 of our briefing. So it's SS5. Am I right in saying that? With my glasses, even at this stage of the day, my eyesight's not great. So it refers to agreeing, you know, it has agreed with the Minister to add the skills mix in children's social services teams, which I think is really positive. And you have a business case with the department's economists, and it's anticipated that final business case will be agreed in the near future. So, I mean, I would like definitely for us to be getting an update, particularly on the back of what Donaghy's just said. My question on that was going to be around the engagement with the Reimagine Children's Services, because unlike Colin, I actually think there are efficiencies out there. I think that money is literally been wasted day and daily. Your department is not exclusive in this, but I think it happens every single day. Myself and Nuala and others are on the policing board. We challenge them on this as well when they're asking for additional resource. Are you making best use of the resource you have? So like they will give us examples like 2 social workers in a hotel with a child. Rightly so. No child should be in a hotel on their own. But if you worked with the community and voluntary sector, they could come up with a much better solution for the child, for a start, at a much lesser cost. We are not working efficiently as a system, as a department, not just trusts, but right across the board, and that actually doesn't deliver good outcomes for that child. Like a hotel is not the place for any child in care to be. So I'm just using that as an example, but it's a really good example of how working with those people who know what they're talking about, who deliver this, who do the best for our children, money can be saved, efficiencies can be made, better outcomes. So I think that's just one example. So I would like us to get an update in relation to that around the children's services whenever that is available. And then just on the mental health services, this is under the neighbourhood model of care. And I mean, again, I welcome the vision, you know, in terms of that regional delivery, but I'm just wondering how that's actually going to be delivered, because I know I'm in the Southern Trust. They do not have the people. That is their problem. This is not about investment. They don't have psychiatrists in particular. So everything they have has been pulled into Bluestone and their residential psychiatry service, and there is nothing in the community, little to nothing. That's not because they don't want to deliver in the community, it's because they can't. So how do we plan to fix that? And that's green. So I mean, does that mean that this is going to happen very quickly? And how is it going to be done? I just need to understand that, because this then feeds into everything else we've talked about. So it feeds into the ambulatory issue, because we have ambulances repeatedly being called out to somebody who is in mental health crisis. They actually don't need to be in an ambulance. They need the right service. They need a pathway. And when I'm talking to trusts and I'm going in with families who have a loved one who's in this position, and I'm saying, what will the pathway be if this happens again? I'm never getting an answer to that. They don't have a pathway. That's a problem. Now, if that's what this is, that's great. But is it what it is? How quickly will we see it? And how will it be done on a regional basis? So are we regionalising mental health services? And I'm not saying that on the basis that I'm opposed to that. I just want the best service for people. I want them, and if it's going to be in the neighbourhood, then it doesn't matter where it's centralised to, because they're going to be seen, hopefully, in their own home, or at their own GP surgery, or at a place close to their home. So I just need to understand a wee bit more about that.
I want to pick up on the mental health stress.
And if you can't answer that in detail, I understand that, because other people may be responsible for
There
this.
will be.
But can we get it?
Yeah, I would say you'll need a detailed briefing on mental health strategy, and the team will be more than happy to do that. What you will be clear when you look across this is that all our strategies almost have three elements to it. One element is what can we do today, and what can the system do to work better. And we know, for example, in terms of mental health in particular, we've moved recently to have a mental health practitioner based in the NIAS call centres, so they're able to deal with some of those queries that, as you say, is not an ED call, it's actually a mental health call. We also know that some trusts are working closely to have some of their mental health professionals available to actually move to the ED to try and get an individual who the worst place to be is in an ED into the help and care they want. And you'll know, as we roll out the MDT programme, we're trying to put mental health services one of the disciplines we're making available at primary care level. So that's the sort of the tactical, the operational element. There's a strategic place where we've got all our, if you like, developed our strategy, co-designed it with users and with the voluntary community sector. And that's the long-term objective, and that's the one where we will continually say, here's where we want to go. The pace and impact of what we do will be impacted by the budget we have available. And then I think there is the responsive element and the change element, the one you're asking for. What is it we're delivering, and what can we actually achieve? That's why those targets are interspersed, a bit like children's services across the piece. But I think I know Peter Toogood and his team are doing a huge amount of work in the mental health space from a strategic perspective. That's matched by Tracey's team on the operational side, and I actually think in this instance the committee would benefit from a much more detailed briefing on that subject rather than the sort of overview I can give you at this stage.
Okay, and I suppose just in terms of going back to that efficiency issue, I mean, I think that one of the problems, you know, we talk about the trusts and how they can make efficiencies, and even as you go down into primary care and how everybody can be more efficient, but some of the problems they have and some of the challenges are actually because of the department. So when trusts are saying, if we change how we do this, they're not able to change it quickly enough, and they're not getting that and this is not to any individual within the department or within SPPG, but they're not dynamic enough. So the wheels turn too slowly. So maybe let's have a wee bit more of an open relationship with the trust and allow them to make changes quickly where they are. You still have to have proven, but this the slowness of being able to.
Can I just make a point that I think is implicit in your challenge to us, which is, if we think about these problems as a whole system rather than everybody in isolation, you're going to struggle. Or you might be able to find better solutions. That's precisely why we've set up this idea of this committees in common, so that they can take a single paper, it's heard by 6 subcommittees of each trust at the same time, and they can come to a decision which then is taken back to their own boards because they remain the ultimate decision makers. So if you take something like psychiatry and the regional service, there's a much speedier way that we can get to all the trusts having a contribution around what they do. And I know Steve Sporry well, obviously from the Southern Trust, who's been saying we're really struggling with our psychiatric service, we're struggling to recruit. That's an area where the trusts now together can start to think about, well, how do we support that? And does that take us more into what would a regional service look like over and above what's available locally? So I think we do have mechanisms to deal with that. And the trusts, in my experience now, the trusts work really close together around some of these challenges in the way that perhaps 10 years ago they weren't doing. So I'm very heartened about that.
No, I know they do, and I'm aware of the committees in common. I think it is a good move, to be honest with you. So look, we'll just have to see how things pan out. But just if I can get even written briefings on those 2 issues, that would be helpful. Thank you.
So just before I continue, we've 2 more colleagues who want in, so we'll try and accommodate everybody if we can keep questions shortish and answers shortish. So Nuala, you're next.
Thank you. I don't know if that was like directed at me.
No. I'm just conscious that we might be coming to.
I have a few questions, so I want to start with commissioning of services, and as I understand it, sorry, I don't know what that noise is. The understanding that commissioning of services is done on a trust by trust basis, which then, from our uncovery of being contacted by medical professionals and patients, leads to inequalities across trusts. And I mean commission of services, and I say that as the whole, whether it's equipment or whether it's staff or whether it's a service in particular. But you're shaking your head, so I'm assuming commissioning services is not done on a trust by trust basis.
Depends on the situation. So when you talk about equipment and services, the trust will have a budget and they will manage that themselves, and they have a bit of flexibility within their budget depending on the outcomes they're delivering. So that could be right, but equally when we're working as commissioners through SPPG and the Public Health Agency implementing the strategies, we look at that as a whole system approach. And what we're trying to do is to maximise where we can deliver it, but it would be on a whole population approach now. So we would have in the past, you'd have very much looked at that as a local population, and we're working very locally, but we're ever more working as a whole system. So I don't know anything that my team are working with now that they wouldn't have. The first conversation is, what does the region need and how can we level the position for patients? Now, there are occasions when we will invest in one trust as opposed to another, but what we're trying to do is to get much more regionalisation. So the example that your colleague had given on the psychiatry position, you know, we're looking at that from a single trust, but we're also looking at it a regional. So commissioning isn't about let's get into that trust, but also there are reasons from a capitation position where you would be saying that capitation's about leveling everyone up depending on where they start from, that you might have to invest slightly more in one area as opposed to the others to balance out inequalities. So it's about all of those measures at one time.
And I think that is helpful, definitely, obviously, for moving forward. And to me, any form of reconfiguration of services would include a review of the services that are operating on a trust by trust basis to make them regional. But we don't really get much of an insight as to how much that is happening. And from our perspective and engaging with the sector, whether it's Royal Colleges or trade unions, they don't feel that they are getting the input into how that is happening, because it will be the delivery of services on the ground. And is that led by yourselves or is it led by the department? Because there surely needs to be someone in control.
I am the department as well, but I am the operational arm of that, so it's slightly different.
It varies.
It varies.
If it's a regional service, then the department will lead regional service reviews as it's doing in neurology, stroke services. They'll look at that, a regional service. Then separately from that, the department will also, with SPPG and PHA, set the context within which hospitals or trusts should look at how they organise their services. And then the third layer that's been added in by Mike is we're now increasingly giving trusts collectively the opportunity through their committee and common structure to say you can collaborate to improve how you deliver the services you have responsibility for, and you can take those decisions as a committee in common as long as it doesn't impact on what we've asked you to do. So there are layers, and I think also it's probably fair to say, and Tracey's correct, there's a big difference between the commissioning of services, new services, and the legacy of how most of the services have been commissioned, and in many ways they are a distribution basis to deliver a service which has changed.
To pick up the colleges, so for example, Jim and I co-chair a number of the strategic advisory groups, and we will have Royal College of Emergency Medicine within that group and different representation throughout. So from the strategic level down, which is informing some of the plans that we're doing, cancer, we have our charities coalition. So it's a broad church that starts it at the beginning of the process, but its core commissioning is about planning for your population need, looking at what is there, performance management and how efficient it is, bringing the partners all together to try and make those decisions. But as trusts have grown over time, trusts will have changed services. So I might commission X, I might go back to find that it's slightly morphed into Y. It never stays the same because they're trying to meet the need on the ground as well. So it won't ever stay the same. It has to be dynamic to meet the needs that are there. So it's slightly different, but we look at it from a global picture, and with our public health agency colleagues who'd be very mindful of us on the inequality space and how we are managing that within those planning dynamic.
One example of that, I guess, is the breast cancer referrals and Southeastern Trust. I'm correct saying that, yeah. But the cancer waiting time statistics that came out today, it said I think it was only 6% of people began treatment within the target. 6%. That's shockingly, that's horrific. You know, when will we likely to see where, I mean, I don't know if you can name, I'm not asking you to, more services that are now done and it does not matter where you live, you will get it in the target. I don't know if we could name a single one that is doing well. How long do you think it will take for the breast cancer targets for diagnosis and then treatment to start, to go the other way?
I would hope you'll see through quarter 3 and quarter 4 significant improvement. We have a lot of investment. We expect it. So what you had was kind of lots of things happening at once. So you put a regional breast list together at the same time. 2 of our trusts brought the Encompass in, which you almost expect a downturn. You're over, unfortunately, the summer period. We always do see a bit of a downturn. Now that is not acceptable. We don't want that. And the energy that's put in, I have a team, and Jim's team, and this has been really an absolute focus as to what they've been doing. We have a number of significant clinics, so regional clinics, going from an assessment diagnosis space over this next period, really pushing through this next quarter. And we have been working with our clinical colleagues, and again, a lot of the colleges, and you'll have had Mark Taylor with you last, Professor Taylor, working with a lot of our clinicians to really see how we generate at pace, at scale. A number of the clinics they are coming online over this next period. So I would listen, if it all goes the way that we have planned it, I would expect to see a significant improvement. And things happen and we have to react to them, but that's the plan into this.
It's always that three. It's that 3 approach. The first stage is what is best to be delivered regionally, and part of the regional approach is to try and minimise inequalities. Yeah. Acknowledging that there's a real service under pressure. The second is what can you do today for the services under pressure, and that's how best to make use of any additional capacity you can bring in, and that's mega clinics. And the third is what do you need to invest today to improve the workforce and capability and capacity you have, and that is just not workforce. It could also be equipment, it could also be imaging. That means in 2 years' time you've got to increase capacity that you won't have these. So.
And you just mentioned one of them, equipment. I've mentioned this to the Minister many times about the robotics, can't remember its fancy name, and the Belfast Trust, and the fact that it was commissioned for urology but told because they were specialists, has now skewed numbers in terms of women's and men's health. And they're real life examples of whenever you do it by a trust by trust rather than regional, where it can have an effect of inequality across the system. And my other question then was around, and this is based on purely anecdotal evidence, the waiting lists that we talked about, meeting the targets and having to use the private sector, which I completely understand, and it's anecdotal. But has there been any work done with regards to the amount of people employed by the HSE that are actually also working in those independent clinics that we are essentially sending people onto? We hear anecdotal evidence where it's I've just gone private for the NHS, but it's the same consultant I was supposed to see under NHS. But again, it's anecdotal from us. But is it a problem? Are we losing consultants because they're choosing to cut down NHS and work in the independent?
We wouldn't have it to answer you in the way that you've asked the question, but if you look to a lot of our consultant colleagues, they will put in a full-time job, in the NHS, and a lot of what we're doing in our waiting lists and the £50 million that we have within the 215 we talked earlier is about cutting the longest waiters. Those consultants are working probably in the IS and potentially also for us to do additional clinics to move this down, or one or the other. So what we're actually asking is for additional time, because when we look at the workforce that we have, and that's why we're having to look at where we can, or where appropriate skill mix, where working with our primary care colleagues provides a better pathway to make sure that we maximise at all points that advanced practitioners and use of our AHPs where appropriate. So it's all of those things. So I don't necessarily see it as a bad thing, but what I would also say is that within the waiting list money, we had the 3 different pots of money, and we've talked about that earlier. But what we had within the 85 million, which is the first plank of that, was capacity building, and that's about in HSC capacity building. And we have, for this year, because of the way we've run into the year, we have more IS, which ran from last year at the first quarters, but that starts to switch through the back end, where we have a lot of the recruitment and the investment coming in more into our in-house. So we want to build the capacity as far as we can in-house, but where we don't have it, and for an area that you know, psychiatry is maybe not the best example in an acute space, but where we have a vulnerable specialty where we cannot recruit, and if we can get it from somewhere else and we need it for our patients, we will always try to maximise the use of that. So it's a mixed economy, but building in-house is where we want to go as far as we can go.
I think it's worth adding to Tracey, you know, all the contracts are what the contracts say, and the consultants work the hours that is part of their contract. What we're doing as part of the waiting list, and Tracey's team is very clear on this, we only pay for additionality once we've received the service and the service levels that we've expected through the commission level. So that we're clear, we don't start paying addition. If we expect X number of operations is what we've commissioned, we will not pay for additionality until the system is able to show that they're delivering X what's been commissioned.
So you must be efficient in your day job before you get access to the additionality from within the HSC, and that was part of the planks that we put in, and it's part of our drive from the efficiency of the whole system was one of the levers that we put in this year.
And one last point on that. When you spot purchase in a sort of crisis from the independent sector, you will pay a higher price. We are going to be working with the private sector on supporting us on reducing those waiting lists for some time, so we're trying to negotiate what a longer term arrangement would look like to help us manage the price of our work with them. So, you know, we are mindful of that's an important relationship, rather than just, as sometimes has happened in the past, when you spot purchase, you end up with higher cost.
And I completely understand to have to use it. My last question is then, if it works for consultants in that sense, then it should be the same for GPs, because if they're working to their maximum capabilities that they are, I mean, the volume of patients, I don't have the figure off the top of my head, that they see each week, each month is bigger than any other medical professional. They can't physically squeeze any more patients into their day-to-day, and I've already had a GP reach out who's obviously been able to watch health committee, because we don't have them that are, like, we have GPs that work full-time hours, but we also have locums as well, and if we had more money we'd be able to get those locums to actually work in the GP service. And allied health professionals, which is more important. The allied health professionals can do the work that the GPs don't need to do. So if it's good for one, it's good for the other. If we expect consultants to carry out their job before they work in the IS, and the GPs are already carrying out their job, and they physically have they cannot fit any more patients into their day.
General practice is effectively independent because they're contractors in the same way. So that's what they are. They just have a national contract. I mean, the point that you raise, I think, which is a really important one, and we haven't talked about it, is that general practice and primary care is largely multidisciplinary now. So the fact that we're investing and continue to roll out multidisciplinary teams is really important for primary care. As a, you know, I completely agree with you. There are so many areas where an allied health professional, like a physiotherapist, for example, is exactly what we should be seeing in primary care, alongside come back to a specialist generalist when you need it. So I agree with you. There's more we could do around supporting, and that's very much as part of the neighbourhood model, that you would see multidisciplinary support, and that gets the best out of the general practitioners that we have, where you need I've called them specialist generalists. They are generalist medical practitioners, but they're specialists at that. They understand multiple problems in the way that if you're a specialist in secondary care, you might only understand one aspect of care in great detail.
Enough. Alan?
Thanks, Chair. Thank you. I noted as part of the stabilisation piece, it referred to trusts now working as one financial unit for the first time. What is the obstacles and what are the stumbling blocks to having a single trust? Obviously in the past in the year we have been told that there is currently not a good time, but when is a good time?
So I'll be very honest with you. First of all, I don't think there is a single trust in the world that has a budget of £6 billion, which is what it would be. Secondly, the first thing that would happen if we had a single governing body for that is that you would have to then have separate divisions covering different geographical areas. If you remember, I think there was an aspiration that local government reform in Northern Ireland would save a lot of money by going to smaller numbers. That's not quite ended up delivering what people anticipated. So there's a bit of a thought that actually if you go to a bigger governing unit, you actually reduce costs. That's by no means proven. It's also the case that you would get a huge amount of distraction by people effectively going through processes around uncertainty about their jobs. And we still need to get the right decision at the right level, which means that you wouldn't want all those decisions taken by one trust at Northern Ireland level, but the Committee in Common allows them to take a shared decision. So we think we've overcome that without structural change and distraction. My view would be that the Northern Ireland model should be more devolved, but we should be clear about what decisions need to be taken once. And I think that's the key. It isn't always about having a single board. It's about getting the right decisions at the right level with a minimum of disruption to do that. And I think the evidence would suggest that. So lots of people have said, oh, well, the answer would be if we just had one trust, that would make all it go away. I don't think it would, and I don't think the evidence suggests it would. So I would not, if I was asked, I mean, if the Assembly said, we absolutely want you to deliver a single trust, then obviously it'd be my job to do it. But if I was asked for advice on it, I would say it's a false hope that it will take cost out and it will improve the decision making. I think you're much better following this line of getting the right decisions at the right level. And certainly trust boards need to be empowered to take more of the decisions that we're actually taking on a Northern Ireland footprint at the moment.
That's a fair enough summary, Mike. I note in the piece regarding prescription charges, obviously in the past, that from my memory has been consulted upon in the past, and there was objections to a number of various health ministers. How will this look? Obviously, there's a proposal here to consult. Will it be similar to the last time, where it be specifically referring to specialist drugs that would fund the introduction of prescription charges? And also, I suppose the question is, given that there was opposition from previous health ministers, what is the current health minister's thinking on it?
Well, I mean, at the moment, the current health minister's agreed to consult on that. So obviously he would be open-minded, I think, in terms of what comes back. I think what we're exploring this time, which perhaps we haven't done previously, is if you're asking people, and there's a number of areas where we're proposing, as you know, to consider charges, which will help us offset the problems that we've got financially and put us into a better long-term position, is could we hypothecate some of those sums? So, for example, if you looked at prescription charges, which some people would pay, could we say that we would divert the money we raise from that to support mental health or to support children's cancer services? So we're really clear about the public of Northern Ireland, they're paying that, and of course it would be progressive in the sense that we'd make sure that people who couldn't afford it would still get pensions. That you would expect that to be part of any thing that we did. But the point being that if we have got money raised from that, can we give the public confidence that that would then help with children's services or with mental health services? And I think we're looking for that route. That might change people's opinions on consultation. If they could see that by contributing in that way, it went immediately to that area of care, I think people might think differently. So we're exploring that.
Just also on the MDT model that you intend to roll out, just so that I understand this, 4 years of that will be funded through the Transformation Fund over an 8-year period. Will there be a cliff edge then thereafter?
Part of the bid for the Transformation Fund, we used a lot of the evidence that we've talked about today as why it's really important that primary care has multidisciplinary teams in terms of the consultations and what that mix should be. But part of that commitment, and it actually goes to the first question that Mike asked about what is the investment in primary care, part of the commitment in order to draw down transformation funding was that the department would prioritise that investment in primary care, would be a call on the budget in year 4, both to fund what we've put in but also to allow the completion of the remaining 5. So that's part of the commitment of transformation is that you've funded, you've invested, you're getting the benefits, and the departments recognise that this needs to be maintained and supported. So the financial sustainability question had to be answered up front, and how we answered that was a commitment to prioritise primary care MDTs within the budget in year 4. So that's part of the discussion we've had.
And the big proposal we've got here, Alan, is that in a way that's exactly a microcosm of the reset plan, is that we can, by resetting our health and care system and managing some of our demand better, along with potential looking at inefficiencies where we've got them, we will be able to live within our means, because those are transformational in character, and a multidisciplinary team who can manage more people who are ending up in hospital allows us to actually, per case, to actually reduce the cost of care. And the options there are 2 things for Northern Ireland. One is that we use that capacity we create to eat into our waiting list without having to pay more money for it, i.e. independent sector, etc. Or we say we'll take that as a saving, and then that's available for other government departments to improve economic inactivity or education attainment. So that's the kind of principle that the reset works on. But it's not without difficulty. We've got to have people committed to it.
Just one quick question. The committee in common, is that one committee, or are there different committees?
The way that works is that each trust appoints a subcommittee, and that subcommittee is made up of their chair, chief exec, and one other of their choosing. They meet at the same time, so there are 6 subcommittees for our 6 trusts round a table like this, and there's a single paper put to them, and the paper says we should come to a shared agreement on, it might be pay rates for locums, or it might be how do we standardise a particular pathway or whatever. And at that point, they all debate it, and they come to an agreement that that's what they're going to recommend. They then go back to their trust boards, because that's the ultimate decision-making body in law, and that's what you would judicially review, in a sense, if you were worried about it. And you would say, the recommendation of our subcommittee to our board is that we accept this is the way we're going to go forward. So effectively it's one paper to one meeting, but agreed by 6 boards.
And who decides the paper, that goes to the meeting?
So the agenda is really set by need, or what areas are relevant for a committee in common. So it comes back to what decisions the trust make in their own right, because it's nothing to do with anybody else. Or what do they take together, because that would make sense, because the system is the best place to make that decision. So you're not employing, one trust doesn't say, oh, we're going to go out and employ 10 radiologists and it denudes the others. You can effectively have a discussion about how do we develop a radiology service, for example. So that's and it doesn't always guarantee they come to a shared view, but actually it's the most straightforward way to do it, and it's very simple governance. It gets the same effect that I think Alan was asking about in terms of a single trust, but you can do it in that way, and it's tried and tested and within our vires.
Interesting. Okay, you've been very
I'm really sorry. Just a very quick, you see the stuff you're talking about in prescription charges. When are we likely to get some more information around that? I'm so old, I remember why they came in the first place, and the reasons why they didn't put it in place, that if you were low income and all the rest.
Any prescription charges or any of the charges?
Sorry.
So it's our timeline for prescription charges and other revenue raising consultations. I mean, those are being developed. I mean, they're there, but ultimately decisions and consultation, will we be engaging with the minister? And I'm conscious many departments are.
We don't have a timeline or anything.
We have a timeline for completing the work and the consultation. We've already been engaged, but when the consultation launched,
we've consulted other government departments. I think so far we've started that process. By
there's no guarantee the minister will even take it out to consultation. Am I right?
Well, I'm imagining the minister will. Other ministers are lots of departments are looking at revenue raising.
I think given the state of our finances that we're currently trying to manage, that and the reset plan, we have to think about asking about charging, and in particular I think if we hypothecate for particular areas of care, I think hopefully the public comes back to your first question of what's the dialogue with the public. Can we get the public to understand when you need us, we got to be there, but in order to be there when you need us, we might have to do some things differently.
I'm starting to think I'm the oldest in this committee, apart from Alan Chambers, who's the father of the house. Am I going to be the new mother of the house or mother of the committee?
So anyway, you three years have been very generous with your time, so we appreciate that and taking our questions. Thank you very much.
Thank you very much.
Get that low.
I'm older than you, Linda.
I might be the oldest in this
No,
committee,
I'm
apart
older
from
than
Alan
you.
Chambers.
I'm older than you.
Did you?
I'm not saying in public session. I'm 34. For everybody listening.
It wasn't
I look 34. Okay, members. Sorry, just to not descend into chaos till I close the meeting.
because that it does go with age, that doesn't it?
So, is there any issues? I mean, there was a few things there that the department have committed to coming back to us on that
Yes,
we've asked. Is there anything else that?
Yeah.
Go ahead. Mary.
I came in last, so felt like I couldn't ask it, but I think the fact that they came into a meeting not able to answer any questions about Alton McGelvin Children's Ward, given the decision today, I think we need to get more information, and not being able to answer it, that they didn't know, like they said, it didn't come across their tables or anything. So I think as a committee we should probably.
Well, they did commit to giving us info. I was a bit shocked that the three very senior officials
Didn't know.
didn't.
Also, was there a wee bit of a, just as they were explaining it, it was like we maybe get an announcement that a project's happening and everybody goes, that's great, and then all of a sudden, no, that's really just paying to get the first part of it done, but they haven't committed. Is there a way that we maybe could get the full capital list from the department and where each one is at in terms of whether the finance has been committed? Because we may find in there one or two where we go, well, actually we thought that was really progressing towards a spade in the ground, but actually the finance hasn't even been sort of
Well, as I say,
confirmed.
those 14 I raised, I was shocked because it's saying in their budget in January these pretty much can't be stopped,
Yeah.
and yet.
And then we're also spending like maybe $1 million or $2 million on a 20 million project, but that's not like getting the shovel in the ground, that's just doing the preparatory work, so it could get pulled, and that means that we've wasted $2 million bringing it to a certain stage. So we'd want to know how much we've committed to the projects and how far along they are.
So there's no saying robbing Peter to pay Paul, and that's what it sounded about.
I mean, again, I was a bit surprised that we could be potentially taking capital money for it, but anyway, we'll get all that information and we can do with it then. So, any other business? No. Date time of next meeting, next Thursday, and Shaw, Thursday, 9th of October.
Yeah.
Okay, yellow warning. Come on, so meeting closed. So I'm saying.